Can you see this slide that has broccoli?
Yes, Professor.
Okay,
Yes, Professor.
perfect. Yes, okay, Professor. Good. Thank you very much. Okay, just a moment. I feel today as if it would be important to cover a little concept also. I want to refresh you some concept about nutrition, tubes, etc. John, are you there? But I see that somebody's recording, so somebody's recording. So I see the button of recording. You can record if you want, and pretty sure that Joan put that to record. Okay, let's go back. Please remember that the test used more frequently to evaluate a nutritional situation of a client is albumin. And please remember that the normal value is the same as potassium, 3.5 to 5 grams per deciliter. And remember that if the albumin is low, is the problem. High albumin is no problem. Ignore the top level. Is the lower than 3.5 the issue? And it translates that the patient for A, B, or C reason, disease, malabsorption, maldigestion, lack economic reasons or whatever, is having malnutrition. Remember that any person that is sick could develop malnutrition. The sickness increases the need of nutrients, and sometimes the person, precisely because he's sick, cannot eat or cannot digest those nutrients. That's why it's so frequent. And especially remember that to heal wounds, soft tissue and skin wounds, a normal amount of albumin is needed. Is one of the points that is more frequently in questions. So if you understand the concept, you will understand the question. Like, for example, which of the following conditions is the highest risk for developing a bed sore, a pressure ulcer? And then they give you conditions that, yes, are risk factors, but are less important than the malnutrition. Incontinence, you can deal with incontinence without developing necessarily, bed sores. I don't know, paraplegia, etc., etc. You can be paraplegic and not necessarily you need to develop bed sores. But they say now albumin 2.8, and probably this is the right answer because it's a very important risk factor because deteriorate the quality of the skin to a level that even in optimal conditions and with optimal care, the patient can develop bed sores. The same for any person that needs to heal because has burns or has a surgery, etc. Have that in mind. Yes, it's true that pre-albumin can be also being used, but I don't see that so frequent as albumin. But it's not going to harm to you to know that pre-albumin is something very similar to albumin, are related, is the same meaning, the same interpretation. The only thing that the normal values are different. Below 15 is significant malnutrition if they are using pre-albumin. And remember that pre-albumin has the advantage that reflects malnutrition sooner, no better, but sooner than the albumin. So since this moment until the person develops the malnutrition is going to drop first the pre-albumin than the albumin. And the other aspect of nutrition that I insist is very important to understand nutrition questions is to memorize the normal BMI, 18 to 25. And not only for, please mute your microphone or ask your question. Go ahead and ask your question. So not only for nutrition and healing, but for example, in which angle to introduce the needle of a subcutaneous shot that could be 45 over 90. You have the two options. Of course, it's going to depend on the BMI. It's a very thin person you are going to enter. It's going to be given because they say their BMI is 18. It's a very thin person. So you're going to introduce the angle at 45. While if they say the BMI is at 30, you can introduce the needle at 90 degrees. So it is important to understand the BMI because you will have an idea of of the constitution of the client. Is okay? So can I move? Yes. Okay. The therapeutic diet, all those diets are tested frequently in your Nclex. And I know that many of you don't like this topic. Okay, I'm so sorry, but you need to like it. You need to read and try to incorporate the most possible, okay, knowledge to your brain, to your long-term memory. So remember that it's very simple, the gluten-free diet, because I think that I taught that very well. Any other person who has not been my students can easily remember that barley, rye, oats, and wheat are the only 4 grains that contain gluten and needs to be eliminated in celiac disease. Celiac disease, you know, is a condition in which gluten is not tolerated and produces inflammation in the intestine and malabsorption, steatorrhea, loss of weight, malnutrition, etc. It's a very serious condition that is simply, the only treatment is the diet. And of course, this is going to be tested in your Nclex if you have a question about this, the diet. This is the question about celiac disease. Remember that wheat is the most common, and become knowledgeable about ways of preparing some foods that have hidden the wheat. So I insist in something like a meatball or a meatloaf that, you know, is meat but is added bread crumbles, or, you know, understand that you have a chicken soup, or you need to see if a chicken noodle soup, because it has noodles, and the noodles, okay, are wheat. If for any reason you're like me, that, you know, your English is not your strong language, please develop a read practice question and develop the habit of checking the meaning of the names of the foods, because I know that for many of you there is an issue, and some of you are, you know, rejecting the fact that you need to learn this vocabulary. Oats is the following, but you know, oats is very easy, because or it is oatmeal or it is oats cookies. And rye and barley are less frequently used. Remember that rye can be rye bread. And well, rye is in whiskey, in bourbon, but you know, I don't think it's going to be in the Nclex. And barley is in beer, but I don't think it's going to be in Nclex in a child, because usually this disease is diagnosed very young in children. Okay, if you have you like mnemonics, brow. Okay, brow is the mnemonic for barley, rye, oats, and wheat. Notice that the initials. The high potassium diet and the low potassium diet is super frequently tested in Nclex, are common questions, and you cannot avoid that. Okay, and sometimes difficult. In reality, the high potassium diet is relatively easy, because most fruits and vegetables are rich in potassium. But the fruits that have the highest potassium content are generally fruits from the tropics. In contrast, fruits coming from cold weathers, like for example, apple, pears, peaches, grapes, berries, cherries, are fruits that grow in cold weathers, are low in potassium. And if you pay attention to this detail, the fruits that, if you're coming from a tropical country like me, fruits that you used to see and eat in your country, and the exotic fruits that comes imported from cold weathers, then I think anybody has, okay, this knowledge and makes it easier. Okay, don't forget that avocado and tomatoes are fruits, even if you don't eat like fruits. Avocado and tomatoes are fruits and are tropical, and for that reason are very rich in potassium. All the citrics are very rich in potassium. If you know what is apricot, please include that in the list. And if you know what is cantaloupe, educate yourself what is cantaloupe in English and the translation in Spanish, so because it's very rich in potassium and frequently in thirst. Don't forget that dried fruits are these fruits but desiccated, and for that reason the potassium concentrates, so it's much higher, the content of potassium. Don't forget, because it's frequently tested, the skin okay, the peel of potatoes and sweet potatoes and those roots that we consume are very rich in potassium, but not the interior, not the starch that is inside. I see frequently in Nclex beet green as a common mentioned high potassium vegetable. Maybe you don't know what is beet green. Maybe you don't eat beet green, but you need to learn what is beet green. What you need to do, Google that. And beet greens have been frequently in Nclex. If you don't have the knowledge, if you are not educated in the food that is usually consumed in this culture, this test is come from this culture, not from our culture, and then that's what make sometimes a little difficult the diet's question for you. Okay, so educate yourself with this beet grain because I've seen that a lot in high potassium diet. Okay, also meats and milk. In difficult, tricky question, you need to know that milk, and any meat is rich in potassium. Low potassium is more sophisticated. So those fruits that I mentioned before, okay, or the tropical fruits that you know that could be low in potassium is watermelon. Generally, the vegetables and fruits that are very watery are low in potassium. It's interesting to know that most of the canned fruits, those fruits that come in syrup, are low in sodium and low in potassium. It's a detail that I see in English question, that canned fruits, peach in syrup, or pears in syrup, okay, etc., are low potassium and low sodium. We are used to think that anything that comes in cans are rich in sodium. Not all. There is an exception, as in any rule. The canned fruits are low in sodium. I seen this detail in English question. There is a series of vegetables that are low in potassium, and broccoli, kale, cabbage, lettuce, zucchini, yellow squash, carrots, celery are all low in potassium. I see frequently green beans. Green beans, you know what is that? These you call that habichuela, okay? These green beans, okay? Green beans casserole, okay? Are low in potassium. And don't forget that salt substitutes are potassium, so it should be avoided in a low potassium diet. If you pay attention to this and you study this, I tried to upload these slides for being safe for you, but I couldn't, so I need to send that other way. The low sodium diet is super frequently tested. And it's a shame that you fail such an easy question just because you don't like to study nutrition or you are not educating yourself about nutrition. So let's see, because empezaron los mensajes. No, nothing is happening. You are seeing it without problem, yes? No problem. You can use, are you seeing me? No.
Yes, Professor.
Okay,
Yes,
sorry, because I got traumatized since last opportunity when the phone was signaling and there was a problem. Okay, okay. Yes.
Profe, can I ask you something?
Yes, go ahead.
Green veggies are not rich in potassium. That's what I thought. The green, like broccoli, kale.
Yes, are not rich in potassium. That's why are included in low potassium diet.
So I saw that they were green and they were good and high in potassium.
No. This
okay.
List, okay. We can double check. But those are examples of greens. Are very rich in vitamin K. Don't confuse vitamin K.
No, I know the vitamin K and I know the spinach, and it's right. It's rich in vitamin K, but I thought that in general green veggies, green color were rich in potassium. That's what I thought.
Yeah. Okay. We can double check. We can.
Okay. Thank you, bro.
Investigate. But now that come to my mind, take care. Okay, because some of us try to confuse because potassium is written with K, and vitamin K is just a K. So sometimes they confuse are totally different and have nothing to do one with the other. And take care with that. So this is the list of stuff. As I said, I think frequently in the questions, the green beans as an example of vegetable that is low in potassium, while beet greens are high in potassium. Why they make so difficult? Because they sound so similar. Okay, I don't know, but have that in mind. So again, low sodium. Low sodium, of course, is in processed food. So anything that comes in a processed way is half cooked or semi-prepared or totally prepared is high in, with the section of the fruits and syrups, as I said before, soups, pickles, all the baked goods, commercial dressings, and anything that you buy in the deli, cheeses, hams, cold cuts, all those are very high in sodium, pizza, bread, etc., etc. So the only alternative to have a low sodium diet is to cook from scratch, where you buy the raw forms of the food and you cook or consume it raw, or you cook it without adding salt or adding just a minimum of salt. Okay, so remember that the recommendation of the American Heart Association is to reduce the sodium intake to 2,300 milligrams per day, which is very difficult to reach. The thiamine is each time less frequently tested, because each time monoamine oxidase inhibitors are tested less and less and less in Nclex, because those are antidepressants that are rarely used nowadays. So remember that monoamine oxidase inhibitors are antidepressants that could produce exaggerated elevation of epinephrine if at the same time you consume fermented food. And when you have the concept of fermented food, understand that beer is a fermentation of barley, and wine is a fermentation of grapes. So now you are aware of what is fermented. And for example, a yogurt is fermented milk, okay, or sour cream, etc. And even very ripe fruits have some level of fermentation. It's interesting that in migraine, to prevent the migraine, to decrease the incidence of migraine, is good to decrease the consumer side. There is a microphone that is open, and everybody's hearing the movement of your gadgets. Okay. The high iron diet is super frequently tested, because it's the most common form of anemia is iron deficient anemia. And we can independently educate the clients to increase their intake of iron. Of course, everybody knows that meats and organ meats are very rich in iron. Of the other animal food that is rich in iron is the egg yolk. But remember that milk and dairy are lacking totally iron. There is no iron in milk and dairy. The green leafy vegetables are very rich in iron, the same as in vitamin K. Got confused with my own warning. Vitamin K and in folic acid. In lentils, and in general, the beans, okay, the legumes, dry fruits are very rich in iron. So probably nobody think that that raisins and prunes could be rich in iron, and they are. So have that because in mind, because it's frequently tested. And this is something that I think a lot in English questions to educate ourselves. And there is a law that says the wheat flour to make breads and baked goods by law need to be enriched with iron, and should be enriched with vitamins of the B group. Okay. The most important enrichment that I've seen in Nclex is that salt, table salt, is enriched with iodine. that milk is enriched with vitamin D, milk and dairy, and breads, baked goods, are enriched with iron and B complex vitamins. Those are the three enrichments that I seen in different type of question mentioned in Nclex, because are like policies of the government to prevent rickets in children, to prevent iron deficiency and vitamins deficiency in people like pellagra, etc., and to prevent endemic goiter, okay, enlargement of the thyroid in the area of the country that are far away from the ocean. And it's a knowledge that a nurse should have. It's important to know that the orange juice, because I've seen that frequently as a distractor, has no iron. And but orange juice is good because as in any high vitamin C content of juice favors the absorption of iron. So the role of the orange juice or tomato juice or cranberry juice or any acidic juice now that is rich in vitamin C is to enhance the absorption of iron, okay? But has no iron. So if there is a cellular apply, which generally those are questions cellular apply, and remember, almost half your test is going to be cellular apply. So be ready for that. I know that you don't like it, but then again, I'm so sorry, you need to like it. Have your test, and you can pass even having this, have your test with cellular apply, because people pass even having half the test with cellular apply. So if you have the knowledge, you can pass. And a very simple question, by the way. And of course, in this cellular apply, if you have orange juice, maybe if you go too fast, you could be tempted to select that as a iron-rich food, and it is not. It favors the absorption of iron, but not rich in fat. Don't forget that milk and dairy impaired the absorption of iron. So drinking too much milk with the food that contains the irons will hinder the absorption of iron. And this is what happens in toddlers. Toddlers are children less than 3 years, no? And toddlers are already eating solid food that contains iron. But then they also have a sweet tooth for drinking milk. And when toddlers drink too much milk, then the milk inhibit the absorption of the iron content in the food. So the rule is, and need to be memorized, that in toddlers, no more than four. Let me erase because I don't want to confuse you. No more than 4 cups of milk per day. You need to know by memory that each cup has 8 ounces, okay? So 4 times 8 is 32 ounces. So they can ask you, and I saw the question, so I saw the students telling me the question, that could be 32 ounces mentioned or 4 cups, you know, or 4 cups, because it's the same. Makes sense, no? And even I can imagine they can, you know, ask that as in milliliters, because you multiply 32 ounces times 30, because you know each ounce is 30 milliliters, okay, and then you have 960, okay, milliliters, okay. So this is something that is basic calculation apply to a knowledge question. The calcium of the milk and the milk in general impaired the absorption of iron. And that's why it produced what is called the milk anemia. in toddlers, okay? Milk anemia. Super frequently tested if you have this knowledge, okay? If you have this knowledge, okay, the milk anemia. What else about iron? Well, antacids, Tums, antacids, etc. also impaired, hinders the absorption of iron. And the best way of absorbing properly the iron tablets supplements is with empty stomach. So if they ask you, if the doctor prescribe iron supplements as a medication, which is the moment empty stomach. And don't forget that empty stomach is 1 hour before meals or 2 to 3 hours after meals, depending on the composition of the meal. High calcium diet, super tested, super tested. Of course, everybody knows that dairy, milk and dairy is very rich in calcium, but they make it difficult because they ask you for alternative for milk and dairy in people that have, for example, lactose intolerance or don't like the milk. And remember that bony fishes like salmon, sardines, green vegetable like broccoli, collard green, spinach, tofu, and fortified orange juice. So orange juice also is another fortified source of calcium, okay? Specifically, I don't saw that, or I don't know that having, but it's an important source of calcium, fortified orange juice. For the absorption of calcium, we need certain level of acidity in the content. That's the reason for which the proton pump inhibitors like omeprazole are taken for long periods of time, months, could produce some malabsorption or deficiency of calcium in the body. Be knowledgeable of that vegetarians, okay, vegetarians can be vegans or lacto-ovo vegetarians, and have this knowledge because it's very different and have a very different implication. Of course, the issue is when the person is a vegan, because a vegan is not consuming anything of animal origin like milk or eggs, while a lacto-vegetarian or lacto-ovo vegetarian can consume that. The issue of the vegan diet is only B12. Only B12. So in the book and in the anchors, what I've seen, a vegan have not nutritional deficiencies except B12. Even a child, even an adolescent, or even a pregnant woman. The trick that I've seen in questions is that it's a pregnant woman, and then you say, oh no, the pregnancy requires a lot of nutrients. You need to know that, yes, it's true, in pregnancy, you need to increase calories. You can increase the calories from the vegetable diet. You need to increase the proteins, and you, yes, can increase the proteins of your vegetable diet. And you can increase your folic acid, and yes, you can increase the folic acid from vegetable diet. And you need to increase your intake of iron, and yes, you can increase the content of iron in the vegetable diet. So the only issue in vegetable only diet is the B12. And remember that they don't need to inject. It's enough to swallow a tablet of B12 because they don't have absorption problem like the patient with pernicious anemia, in whom is the deficiency of the intrinsic factor because they have sick or absent stomach, the issue. That's why they need to inject the B12. But vegans don't need to inject the B12, okay? As I said before, pregnancy requires increments of calories. And they ask how many calories, okay? So in the first half of the pregnancy, 300 extra. In the last part of the pregnancy and while breastfeeding, 500 calories. This is an accepted value by the book and by whatever that has been tested. So remember, when a woman becomes pregnant, needs to consume more calories. So if the woman was consuming a 1600 diet, in the first half of the pregnancy, need to increase 300 calories per day. So will increase to 1900 calories per day. But in the second part of the pregnancy, at the end of the pregnancy, this value need to be increased to 500. So now it's going to be added, okay, 2 more. So it's going to be, it's going to be a diet of 2100, okay, calories. So this is something to memorize, this value and this value. I saw that in question must be memorized. The other value that you need to memorize is how much should be gained in weight in normal pregnancy. 25 to 35 pounds. I've seen a lot of tricky options, 20 to 30, 22 to 32, something like this. Take care. This is the answer, the right answer of those questions. Very repetitive, very repetitive. How much should be the weight gain of a normal pregnancy? And I already mentioned that you need increased iron, proteins, folate, okay, in the diet. Don't forget that women need to be very careful with the big fishes, especially tuna, but any other big fish, okay? Any other big fish. Probably you are more knowledgeable about fishes than me, but tuna is the most frequently used because they have a high content of mercury, because our oceans are very contaminated with mercury, and the bigger the fish, the predators, fishes, okay, are having more mercury content in their flesh, okay? Women need to be very careful with not eating cold cuts. I mean, cheeses, meats, like, I don't know, bologna, ham, and all this stuff, because they can contain the bacteria Listeria. Listeria is a bacteria that can make the woman has an abortion, and should avoid consuming raw vegetables of no safe origin, because the risk of incorporating the toxoplasma that is also harmful in pregnancy. Those are the issues in pregnancy. You need to be knowledgeable because it's frequently tested what happens in the first. Somebody has the microphone open and then we have an echo. Yeah? Yes. Okay. Yeah, go ahead.
The raw vegetable that you talk about, does it include like salads?
Salmon is not a
No,
predator food. Salads.
Yes.
You mean that salads as a raw vegetables?
Yes, like
The most common, obviously, a salad can be cooked, can be just salad mean combination, no? But raw vegetable salads, okay, are included there.
Okay.
Because there is something that could be in the poo-poo of animals, cattle, pigs, cats, dogs, and even humans can have toxoplasma, a protozoa, and the cycle of this protozoa is fecal oral. And when this animal poo in the farm, in the field, where is growing the lettuce or is growing the, I don't know, whatever the vegetable, the strawberries, etc., then the person can incorporate this toxoplasma in their GI. Toxoplasma produces a very mild disease in humans, very mild, just like a flu-like syndrome with low fever or no fever at all, enlargement of the lymph nodes, a little malaise, myalgia, and then disappears and generally cured, leaving permanent immunity. But if this disease occurs in the moment of the pregnancy, in any moment of the pregnancy, but of course, more important, the first 20 weeks when the organogenesis is happening, can produce destruction of the brain and destruction of the retina of the fetus, not the pregnant woman. The pregnant woman has no problem. It's the fetus. So for that reason, need to be very careful with this fetus. That's why any medication, just a few unauthorized by the doctor, should be consumed. That's why any radiation, X-rays or should be only really necessary, should be done, because the fetus is very delicate. Remember, the fetus is immune suppressed.
Is that a parasite that also cats poops have? That sometimes they tell pregnant women to try not to clean the cat's litter because it
Makes
contains.
sense, no? Fecal oral, cats, dogs, cattle, pigs, even person can have this stuff. Okay, so what makes sense? Women that are pregnant should not be dealing with this feces because this increases the risk of incorporating the toxoplasma. It is super evident when we understand this disease. Not because the woman, it's because the fetus. Okay, so now you understand why. Why? Okay. And yes, in the of all those animals, the most commonly bringing the problem because you have those animals in your houses, and those animals have the possibility of being trained to have a cat litter, a sand there where they put there, and we clean that. Okay, any person that had cats in their houses know what we're talking about. You don't have an apartment or something like this. So of course, this is something that in this civilization, in the Occidental civilization, pets are important. People live in apartments, they have cat litter, and it's very possible that a person is cleaning a cat litter. This is something that is frequent statistically, and that's why specifically they insist in this little. But any poo-poo can bring the toxoplasma to us. You need to understand that those vegetables that you consume raw grow in a field that at night is left alone, so animals can be there and can poo, etc. So now you understand why there had been recalls of lettuce, of strawberries, of cilantro, etc., because have been contaminated with E. coli, enterotoxigenic E. coli, or with these, or hepatitis B, hepatitis A, etc., etc., etc. Okay, so now you understand what is fecal oral, that yes, we can eat poo, even it is a microscopic amount that we don't see, but yes, we can eat poo. And when we eat poo, we can get those diseases like hepatitis A, like toxoplasma, etc. It's clear now? Okay, let's move on. In the first years of life, don't forget that the baby will double their weight in 6 months. It's tested in many ways. So if they tell you that the baby was born with 8 pounds, you expect at 6 months at least 16 pounds. If they come with a baby 14 pounds, then when you say failure to thrive, failure to grow, there is a problem here. Yes. So this is the scenario, this is the question, and you have this situation, and what you do, apply your knowledge. This baby was born with this weight, should be weighing double at 6 months. It's not weighing that, so my brain, there is a problem here. And this is the patient that need to follow up. They usually use these terms. Now we want the patient that need to find more, investigate more, follow up, okay, dedicate more time, etc. Try to find the way that I frequently they use the term follow up, okay? And of course, triple in 12 months. But the other concept that you need to have for this is that of all human beings at any age and in any condition, babies are the one that needs more food proportionally for their weight, for each pound of weight, for each kilo of weight. Yeah, I weigh almost 200 pounds, and the baby is weighing 8 pounds. Do you notice the difference of pound? That I have more pounds, but for each pound, the baby needs more calorie, more food than me. Understand? Okay, proportional to their small weight. Okay, they need more food than any other on a stage of life, without exception. And that's why babies are very susceptible to malnutrition, because any disease, any economic reason, any neglect, any cultural issue, any whatever could affect them. And they ask you if you know that, period. This is a concept that you need to have. You understand the concept, you have the question. This is not question, this is the concept. Have the concept clear, understand the question, the concept. When the question comes, you know what to answer. Okay, don't forget the detail of the honey in babies, no honey until 1 year at least, okay? Because honey can contain botulism spores, and for that reason, they can develop neonatal botulism or infant botulism. No honey in children, okay? Remember that the first year of life, no cow milk, any animal milk, only human milk or formula. Formula is an artificial milk that mimic the concentration and the content of the human milk. Yes, so no problem between they both. Both are good. Formula and breast milk for the baby are the same from the nutritional point of view. Okay, there are, of course, all we know that there are advantages in breast milk because the way that is delivered for the woman, the benefit for the baby because the defenses that have been passed to the breast milk. But there is no different from the nutritional point of view. There is no advantage of one over the other, of any one over any other, comparing breast milk and formula. It's the same for the baby. But what is prohibited is cow milk. Cow milk can be incorporated after 1 year of age and need to be whole milk. So this milk that we adult tends to consume like 2%, 1% of skim milk is a no-no in childhood, okay? The way of preparing the formula can be tested. It is a calculation question. It's a way of doing that. So they give you the proportion and then they give how many ounces is going to drink the baby, and you need to know how to calculate how many measurements of the milk need to be added to have a cake. Don't forget that the dilution need to be respected. You cannot change the dilution. Even if the child has diarrhea or whatever, cannot change the dilution. And don't forget that while the baby is consuming only milk, which is going to be 4 to 6 months, the baby doesn't need to drink water, a part of the water provided by the milk. And you know that the way of knowing if the woman is breastfeeding or feeding by bottle, to know that the baby is well hydrated and is receiving enough water, is that the baby should wet 6 to 10 diapers per day. It is the way of knowing if a baby is consuming enough liquids. 6 to 10 diapers wet with urine per day. This is the way of knowing that. You know that the solid food is introduced, okay, after 4 to 6 months. There is a range of time in which it could be introduced. When the baby start consuming, solid food, then they can add other liquids different from milk, okay, like juices and water. And don't forget that the new food should be introduced one by one, separated by 1 week or more, to notice if there is any allergy, adverse effects, etc. Be knowledgeable about a food that, because the shape and the consistency, could produce choking in small children, because it's frequently tested. So now you need to think in peanuts, you need to think in, in baby carrots, you need to think in anything that that because the shape and the consistency could produce choking. A patient is a lacto or vegetarian diet. What type of food can be eat this patient? It could be a way of asking that. What do you think you can bring in the tray to a patient that requests a lacto or vegetarian diet?
C.
Exactly. C is the right answer. It has eggs and milk, and they can consume that. Perfect. Gastroenteral feeding. You need to understand that the gastroenteral feeding means that a tube is going to be placed in the stomach, less frequently in the intestine, specifically in the jejunum, because the client cannot swallow. So the issue to place a tube in the stomach or in the intestine is impossibility of swallowing. A person could not be able to swallow because his brain dead, is in permanent coma, or a very severe deterioration of the level of consciousness for long periods of time. Okay, you see people that are left with permanent brain damage, okay, and they cannot swallow. People that have dysphagia, they are conscious, they are aware, but they cannot swallow because they have dysphagia, because it has a neurological condition that produces dysphagia, like, for example, Parkinson's disease, like, for example, a stroke that affects the swallowing, which is not frequent, it could be, like, for example, multiple sclerosis, like, for example, any neurological condition that could produce, okay, swallowing issues, ALS, etc., etc., is another example. Or people that have obstruction because of any problem, tumors, etc., and then they cannot swallow the food, okay? And for that reason, the people need nutrition. Nobody can survive without nutrition, especially when they are long-term. And for that reason, doctors order to place a tube in the stomach to do that. Of course, the simplest tube is the nasogastric tube that a nurse, a registered nurse, can introduce. And this nasogastric tube is generally used in very short period of time, because a nasogastric tube is something problematic, brings problem. Why a nasogastric tube brings a lot of problem? First, because it can be pulled out in any moment without witnessed by the nurse. And when the tube is pulled out, obviously now the tip won't be in the stomach anymore. The tip won't be in the stomach anymore. And the moment that I'm trying to change it. Now that the tube is pulled out, is not in the stomach anymore. Now the tip of the tube is in the esophagus. And if you don't realize that, if you're not educated or smart enough, trained enough to notice that it could happen, when the tube is here in the esophagus, because having pulled out, and you introduce food or liquid or medication, it's very easy that this medication migrate to the other tube that you have in front of the esophagus, which is the trachea, producing something risky and potentially lethal, which is aspiration, with suffocation, with pneumonia, etc., etc. So this is the number 1 problem of those tubes. That's the reason for which a nasogastric tube, each time that you are introducing anything there, need to be checked for placement. What means that you need to verify that the tip of the tube is in the stomach. Of course, the first time that is introduced, an X-rays, okay, X-rays is done, because those tubes can be seen in the X-ray. You can perfectly see, and the radiologist is going to confirm that the tip of the tube is well localized in the stomach. Yeah. But those X-rays cannot be repeated each time you are administering food or liquid. So don't use anymore this old technique of, even if you saw that in clinicals or wherever you've been working, introducing air and auscultating with an stethoscope, okay, to see if the air is producing sounds, okay, gurgling here in the stomach. No, don't do that anymore, okay? So it's very important that it has been eliminated, discarded from checking placement. The only effective is that you are going with the same syringe, but you are going to suck the gastric content, and you are going to test this gastric content with a simple strip, okay, that check pH, to see if the pH is acid or not. A pH, okay, a pH, 5 or less, so it should be say equal or less, and 5 confirm that the tube is in the stomach. The tip of the tube is in the stomach because the only liquid that could be this acid is the gastric content. Any pH that is 6 or more brings the doubt of where is the tip, and then required withholding the introduction of the liquid, contacting the provider, and provider probably is going to request an X-ray, an extra X-ray. Also, is useful to mark, okay, after insertion and verification that the tube is in position, mark, you know, where the tube contacts the nair, the border of the nostril, and it is a way of suspecting that this pull out. The other reason for which tubes are no is because they bring infection to the lungs even without aspiration. It's because the presence of the tube in front of the trachea translocate bacteria to the trachea. And as you know, and when it brings other problems, like for example, discomfort, they produce sinusitis, etc., etc. So for that reason, rarely are used. So more frequently, when there is need of long-term feeding, what is used is the PEG tube. PEG tube is a tube that is directly introduced through the skin. It's percutaneous. That's why the P, percutaneous, through the skin of the abdomen inside the gastric cavity. So this is done very easily with an endoscope. The endoscope will guide the doctor where to make the incision. Is minimum invasive with local anesthesia. So it can be done ambulatorily in the doctor's office. And they introduce the tube and they inflate the balloon. So the tube stays inside there. But again, because there is a remote possibility of dislodgement, then you need to check for placement each time you introduce food or medication there. And the checking is the same, the pH, okay? The only interesting to know about when the tube is introduced in the jejunum is that the jejunum is very narrow, while the stomach is very wide. So it means that the amount of food that could be introduced at once here in the stomach is much, much bigger than the amount of food that could be introduced in the jejunum. No more than 30 milliliters, 1 ounce could be introduced at once in the jejunum. Okay, yes, go ahead.
Yes, can I ask a question? The only form to verify the placement of the nasogastric tube is the pH, or I can do the radiography?
Okay, trying to listen to me. The X-rays is done always the first, okay? So the patient is going to have an nasogastric tube for 7 days, okay? The first day is Monday, yeah? Monday, the 9th, okay? And you do introduce the tube and you do the X-ray. But now days are passing. So on Wednesday, okay, or Thursday, okay, you need to give food to this client. Is this X-ray telling you that the tube on Thursday is still in right position? Yes or not?
No.
No, because could be pulled. So the X-ray is useful only for the first time, but then now on, each time you're going to give food, well, probably 3-4 times per day or more, you need to check for placement with the pH. If you do an X-ray, okay, every day, 3 to 4 times per day, then the patient is going to be very safely localized the tube, but the patient will develop a leukemia because the amount of radiation that is offered. You understand that you cannot do an X-ray each time the patient is going to be fed?
Yes, Professor.
So now you understand when the X-ray, when the pH. And what I said, if the pH is not acid, then doubt, I don't know where is the tube. So now a second X-ray could be, in this eventuality, could be ordered by the physician. So this is the way of understanding when X-ray, when pH, and of course, majority of the cases pH, and meanwhile the pH is acid, you are comfortable. You are comfortable. Don't worry about the volume of residual. It is not tested anymore because in the past, when I studied nursing, they say it cannot be more than 100 milliliters. Now those concepts have changed. Each person, each client has a different normal residual that need to be determined by the physician. And it's something that could not be tested. Which volume is the adequate residual? Residual means that the amount of liquid that you suck with the syringe before introducing new liquid or new food. You know, that they say, oh, if you had 100 or more, don't introduce more liquids and call the doctor, or stop the feeding, wait 1 hour and recheck, and it's still more than 100, call the doctor. It is not anymore because the policies, that the evidence have changed these policies, okay? So understood the difference between jejunostomy and PEG tube. If they ask you, because it was a question, what is the difference in the nursing management, what a brain of a nurse need to understand that is different in a patient with a PEG tube and a person with a jejunostomy, no? And there's the capacity of nutrients that could be introduced because the difference of size, as I explained before we went to the explanation of the X-ray. Okay, so pay attention to this detail, okay? And remember that if you introduce a huge amount of inadequate concentration of food formula in the jejunum, you are producing something called dumping syndrome. And you should know what is a dumping syndrome, because it's presented, is reviewed in the career, okay? So you can have a dumping syndrome if the jejunostomy is not managed properly by the doctor, the dietitian, and the nurse, okay? So this is the topic that you need to have, okay? What else? Well, yes.
I have a question. In the jejunum, the pH is
Alkaline. It's alkaline. Remember that the
yeah,
intestine
the same than in the stomach.
is not the same. It's alkaline. The stomach is acid. Good question.
Okay.
The pH in the stomach is acid, but the pH in the jejunum is alkaline. There is no pH checking in jejunostomy.
Oh,
okay? No, there is
Where-
no pH.
Where
There is
should
no.
check? Where we should check?
Okay, this is a little specialized feeding a patient with jejunostomy. Those patients that have jejunostomy, okay, don't need, are going to be receiving the feeding continuously in a continuous drip. So it's not like in the PEG tube that you can give 3-4 times a bolus, okay, feeding to the client, no? So they are going to be receiving continuous feeding precisely because it's so narrow, the intestine, they cannot receive a bolus feeding, need to be a drop every second, okay? So it is going to be a dropping, and it's different. For that reason, there is no need of being checking, okay, the placement, because continuously the feeding is administered, okay? And any dislodgement is going to require the doctor's intervention, okay? But what you need to understand that the jejunostomy, a part of this, that is the pH is alkaline. Remember that the pH of the stomach is acid and the pH of the intestine is alkaline. If you vomit or you have nasogastric suction, which is the most common reason for having a nasogastric tube, you lose your acid, you develop alkalosis. You need to have a balance between your acid and your bases. If you lose your acid, what is going to win is the base. If you vomit or have nasogastric suction, the stomach is acid, you lose acid, and is going to win. What stays in your body is the base, yes, and wins the base, yeah. But if you have diarrhea or a fistula or an ileostomy, yes, ileostomy, you should know what is an ileostomy, and you have a massive loss of intestinal content, intestinal juices, not colon, the small intestine, yes, This liquid is alkaline, is basic. And then what you lose is bases. You lose the bases. So who's going to win? The acid. So this diarrhea, fistulas, and ileostomies can produce metabolic acidosis. So now remember that the gastric content is acid, the intestine content is alkaline. Okay, so it is an important. So the pH here is checked, but this is the most common situation. This is the most common scenario, and this is what is going to be tested. Okay, that you check for pH because it's frequent, is practical, is cheap, and is adequate to know the placement of the nasogastric tube or the PEG tube. Yes, okay. And that's it. The others are, stuff that that those patients need to be kept all time, head of the bed elevated. And if you need to place the patient flat, you need to stop the feeding 1 hour before. And remember that medications that cannot be given with food requires stopping the medication, the feeding for 1 hour, and then giving the medication 1 hour later, etc. Stuff that you study in fundamentals. Okay, but the most important is to understand that and to understand why those patients require those tubes. Okay, those tubes. Okay, and how to check for them. The parenteral nutrition. The parenteral nutrition is used when there is no possibility of feeding the client, as we explained here, in the intestine. The best, safest, and cheapest way of feeding a client that cannot swallow, have diseases, is with a tube in the stomach or the jejunum. More frequently in the stomach because it's the most common. Yes? But sometimes the intestine is not functional. So this intestine is not working. So the intestine is too inflamed, Crohn's disease, etc. Or the intestine is paralyzed, like for example, post-surgery or in the pancreatitis, etc., etc. In the burn climb can be paralyzed intestine, ileus paralyticus. So in those cases, the intestine cannot be used to feed the client, and the client is needing nutrition. So now doctors need to place a catheter in the superior vena cava. So this is important to understand. For total parenteral nutrition, you need to assume that the doctor placed a catheter in the superior vena cava. It is due for the fact that the liquid used for TPN, for parenteral nutrition, is so thick, to make you understand. It's hyperosmolar, but thick, that cannot pass through a peripheral vein. Need to go through a central vein. The concentration of sugar of the TPN is between 25 to 50%, okay? So 25 grams to 50 grams per each 100 milliliters. Usually in a peripheral vein, you tolerate maximum 10%. But this concentration is too hyperosmolar to be tolerated through a peripheral vein, those veins that we take in the arms of the client. So that's why it needs to be a central vein. In the central vein, there is a high flow of blood. And for that reason, the liquid that is infused there is going to be quickly diluted and is not going to harm the client. But now you have the implications of the central catheter. One immediate implication is the possibility of a pneumothorax. So when the doctor introduces this catheter, can produce accidentally a pneumothorax, or can produce a hematoma because can pierce the artery instead of the vein. So you know that they enter the catheter through the subclavian vein. It's called subclavian because it's under the clavicle, no? Subclavian. But it is introduced in the vein, but at the side of the vein is the artery. So accidentally can pierce that and produce a hematoma. The other possibility is dislodgement. If this catheter comes out, extravasation in the mediastinum, in the chest, Okay, it's very serious because if you introduce a milk and the milk is going to be a spill in the mediastinum, then you understand that is something very serious, no? Any extravasation here is not good. Okay, you don't introduce milk, but it's just to make you understand that is could be a drama. The last but not the least is that this catheter is going directly to the heart. So if for any reason a bacteria contaminates the catheter, now the infection is going to be in the heart and is going to be sent to all the body. So quickly the patient will develop a sepsis. So the most possible and serious consequence of this way of feeding people is the possibility of causing a septicemia, a disseminated infection in all the blood, which could be, lethal. So now you understand that TPN is delicate, TPN is risky, TPN is expensive, TPN requires specialized personnel, and somebody that need to be under the attention of a skilled nurses. While the PEG tube is something that can be managed even at home by the family. Okay, so it is, you notice the difference of importance of that. So you need to assume that TPN is only used when necessary. Meanwhile, the intestine is available, should be used in testing. But when cannot be used, then TPN is used. Anything with TPN need to be super sterile, and then you need to practice the chain of dressing of this because it's frequently tested, and a lot of precautions need to be taken. A detail is that this catheter should not be used definitively and without doubt should not be used to administer other kind of medications, IV antibiotics, blood, etc. It's exclusive for the TPN. If medications or transfusions, whatever need to be given, need to be taken another vein, usually a peripheral vein for this purpose. TPN is exclusive. The vein of the TPN is exclusive for the TPN. Okay. You need to be aware, thinking in the stuff that are tested, that what are the complications to monitor in a client with TPN. Okay, the most important is infection. So now trying to imagine the question. Patients in TPN that is having fever. Patient with TPN that is having increment of leukocytes. Patient with TPN that have in the site of insertion here in the skin where the catheter is penetrating in the skin signs of infection like redness, swelling, and suppuration. I mean secretion that suggests pus. So trying to think in all those possibilities. But another common complication is hyperglycemia. So this patient is going to be receiving directly in the vein a very high concentration of dextrose or glucose. So even if the client is not diabetic, will have high probability of developing hyperglycemia. So hyperglycemia, talking about the blood sugar in 300, for example, is not rare. It's something that is like expected in a client receiving TPN, even if the client is not diabetic. And this is what you need to understand. So you assume that doctor will include in the order of TPN insulin if needed. You know that insulin as needed is given through a sliding scale. You should know at this level what is a sliding scale. It's a scale given to you to the doctor where you don't need to call the doctor if the blood sugar is higher than normal, because this sliding scale will tell you how much insulin, usually regular insulin, is given to the client depending on the guideline sliding scale. So if the sliding scale say that, okay, then less than 110, zero insulin, 110 to 130 is, no, déjame estar más grande, 150, okay? No, see, 150 is 2 units. 151 to 200, okay? It is 4 units. 200 and 201 and 250 is 5 units, 6 units. And 251 to 300 is 8 units, and the patient had 300, then you know that you need to give 8 units of insulin to the client, okay? And you're going to be repeating this every 4 hours or every 6 hours as ordered by the doctor, so frequently. So is acute check, is capillary blood sugar a requirement in those clients? Yes. How frequent? Frequent, but the exact frequency is going to be variable. It's going to be ordered by the doctor, okay? So it is important. Of course, you need to weigh the client every day to determine, fluid balance and to determine, stability in the weight. You need to have a careful measurement of I and O. Anything like electrolytes and blood tests need to be checked practically daily. And those are the parameters that we are using. It is frequent that you have a cellular apply what you need to monitor in a patient with TPN. And here you have the most important, okay? So those are the most significant aspects. So for example, if I have a question like this, the nurse understands that only one of the following clients needs total parenteral nutrition. And which client has a formal indication? Of these 4 clients, A, B, C, and D, which one you think has a formal indication of parenteral nutrition?
A. C.
C.
Okay, so let's go. A patient has a stroke. Let's go one by one. A stroke and dysphagia. It's very common, okay? And for that reason, had in the past an aspiration pneumonia. So, okay, so this patient can chew and swallow? No. Why? Because the risk of repeating the pneumonia. So what is the recommendation with this client? Place a tube in the stomach, a PEG tube, and feed the client through the stomach. So there is no need of parenteral nutrition. The B has a head trauma, is in coma, and is going to be in coma for a long time, has a bed sores, and requires adequate nutrition. This patient cannot swallow, so obviously, but the intestine is competent, so you need to place a tube in the stomach and feed the client. This client has a severe malnutrition and has a severe chronic diarrhea. So if this client is allowed to eat, because she can eat, I assume that is she because it has an anorexia nervosa. She can eat, but then what is going to happen with diarrhea? It's going to become worse. So it looks like the intestine of this client is not competent. A patient with an obstruction of the esophagus and is in radiotherapy, okay, cannot swallow because has obstruction of the esophagus. Okay, no problem. Place the tube in the stomach. The stomach is after the esophagus, no? So the tube was in the stomach. So no problem, put the tube in the stomach and the intestine is competent, no problem. So obviously the right answer to this question is C. This is a reproduction of a question, okay, that, Nclex question where you understand, what concept you understand? You understand in your brain that TPN is expensive, risky, delicate, required a lot of conditions, and is only justified when we need to give nutrition to a person that cannot use the intestine. Meanwhile, the intestine can be used, okay, independently of if the patient can swallow or not. If the doctor places a tube in the stomach, food can be given there. Food, okay, rice and beans can be given there. Okay, but the problem is when the intestine cannot work, and you need to find this. So similar question. Okay, another question: a nurse is caring for a client who is receiving TPN. this person, as I said before, is having very high blood sugar because of the TPN. If the patient has pancreas, and the most probable is that the patient has pancreas, the patient will produce enough insulin or almost enough insulin to deal with this elevation of the blood sugar. So we'll have hyperinsulinism. So we'll have more insulin than normally. And if still the pancreas is not enough to catch up with this elevation of the blood sugar the patient could have, then insulin is going to be injected and added to the client. So now you understand that a patient that is properly, correctly controlled in TPN is having a almost normal blood sugar because it's having more than usual insulin in the body. Don't forget that it's important to have a blood sugar controlled, not because high blood sugar is going to kill anybody immediately. High blood sugar doesn't kill a person immediately. You can have 300 milligrams of blood sugar and you will not die for that reason. Yeah. The problem is when you surpass certain level, which is variable, then you are going to have what is called osmotic diuresis. Is because when you have more than certain threshold, more than certain limit of blood sugar, then the sugar, the glucose, starts spilling in the urine. And once this molecule is in the urine, will attract more water from the body. So now the patient will pee more than usual. It's called polyuria. But because this water is coming from the body of the person develops dehydration. So is the polyuria, you know what is polyuria, and the potential dehydration in the upcoming hours after the polyuria started, what can produce a decompensation of the client. This is the most common scenario in the client with TPN. Why we give insulin? To avoid the osmotic diuresis and the polyuria that could dehydrate the client, even if the client is not diabetic. Don't confuse the patient that is, yes, diabetic and has type 1 diabetes, in which another problem is added to the dehydration because the osmotic diuresis and the polyuria. This added problem is that those clients, because of lack of insulin, can develop metabolic acidosis, ketoacidosis, which is going to complicate the situation. So have in mind, okay, all the possibility, because you have already studied all those situations and you know what happens in diabetic clients, but it's going to be depending the type of diabetes, or if they are not diabetic, just hyperglycemic. Understood? Okay. So now the scenario is the following. The TPN, for A, B, or C reason, ran out. No more TPN. You are the nurse, and you have a patient that now has another bag of TPN continuously dripping in the vein of the client. And you know that the patient is having high levels of insulin. So what is your concern? The most risky, acute, immediate complication of these metabolic glucose metabolism problems, which is the hypoglycemia. Okay, so for that reason, as a protocol that the nurse must know and is tested in Nclex, because as I said, those are topics that have been tested, you are supposed to know my explanation, the explanation that I'm giving to you, that this patient has an hyperinsulinism, and this patient, when they are interrupted so abruptly, the TPN is at the risk of developing hypoglycemia, and hypoglycemia is more acute, more emergency, more risky than the hyperglycemia, yeah, because it's a slower decompensating the client and is, giving you more time. So now you need to know that protocol, if for A, B, or C reason the patient runs out of the TPN liquid, you need to start a 10% dextrose solution, a regular, usual, common 10% D10% W solution. And this is a protocol, and that's the purpose of the question, okay? There are several stuff that you need to study for Nclex that should not be discontinued suddenly. You are supposed to know that to pass, to be a nurse. You need to know that one of those stuff that should not be discontinued abruptly, never, is this, the TPN. You know that the other one, and the other ones are glucocorticoids, should not be discontinued abruptly. You know that can produce adrenal insufficiency. Beta blockers, olol, metoprolol, atenolol, should not be discontinued abruptly because can produce rebound hypertension, rebound, okay, angina. Another medication for blood pressure, frequently mentioned, that should not be discontinued abruptly is the clonidine. And maybe you don't know very well this clonidine, okay? Clonidine, okay? Clonidine, okay? Very well. And the same way, okay? There are, okay, other medications that should not be discontinued abruptly, but those are the most seriously consequences. And glucocorticoids, beta blockers, clonidine, and TPNs are the most frequently tested medications that should not be discontinued abruptly.
Anticonvulsant as well.
Yes, anticonvulsant could be another example of medication. Absolutely, yes. Absolutely, yes. Okay. Nutrition and religion. Frequently tested in Nclex. You need to be culturally sensitive and culturally competent for Nclex. Nclex gives a lot, and there is a lot of culture question usually in Nclex. So you need to develop the knowledge that the most common religions have dietary requirements. So for Muslims, okay, that are the people that you know, that have the Islam, okay, religion, they cannot have pork in any form. They cannot consume alcohol in any form, and they have 1 month per year in which since sunrise to sunset, so meanwhile the sun is out, period. They cannot drink, okay, not everybody. They exclude people that are sick, pregnant women, some children, etc. But people that, you know, that practice Orthodox people that practice this religion, they don't drink or eat while the sunlight is out along 1 month. It means, okay, that they eat and drink at night, but not during the day. And then you need to accept that. And then you need to be sure that at night they are taking the adequate nutrition and the adequate hydration if the client is under your care. Okay, so you need to adapt to that. But then what you do is to change everything for the time that they can drink and eat. I've seen that in question. If you understand that and you are respectful of the other people, you will be able to answer the questions. Orthodox Jewish have a kosher diet, okay? A kosher diet. And the most important aspect of the kosher, okay, the kosher diet, okay, kosher diet is that they don't consume pork neither, okay? Are they like the Muslim? They have those have Abrahamism, okay, religion, both the same as ours, the same as Christians, okay? So they don't consume pork. They don't consume shellfish, but they can consume fish. fish with a scale, but not shellfish. So you need to know what is shellfish, okay? So you need to know what is shrimps, crabs, oyster, clams, etc., etc. No rabbit. I never seen this in English question, but this is something interesting. They don't consume rabbit. Okay. Okay. They can eat beef and can't consume milk and dairy, but they cannot combine them. They need to separate 3 hours one from the other. So if they eat beef now and wants a yogurt, need to wait 3 hours. And certain meals, like for example, certain pasta that have meat and cheese, a lasagna, for example, is not allowed in this diet. A cheeseburger, that you know is a hamburger with cheese, is no in this diet, etc. Jehovah's Witness is the problem of the blood. So anything that is raw meat or blood sausage is a no-no. So sushi and that, no, for Jehovah's Witnesses, okay? If the client comes from India and practices Buddhism or Hinduism, they are vegetarians. Everybody knows that. Mormon, frequently tested. You know, Mormon is a Christian American religion. No caffeine is the most important. Remember, caffeine can be in soda, can be in coffee, can be in tea, can be in energizing drinks. No alcohol and tobacco, but the problem is the caffeine, the frequently tested. You need to eliminate because it's diet, it's not the other stuff. It's diet, the question, okay? No caffeine. And recently was a question about a Christian Protestant Christian group, which is the Seventh-day Adventist, the Adventist religion, that they are very similar to the Orthodox Jewish, and they favor the vegetable, the ovo-lacto vegetarian diet. Okay, so please be knowledgeable, especially the Jewish and Muslim that are the most frequently tested. Okay, okay. Oh, I want you to have this slide because each day I see more and more students commenting that they had questions about herbals in Nclex. You need to know the problem of herbals is that a lot of people believe in herbals. They are over the counter, so they are not regulated, and even they are not regulated by the Food and Drug Administration. And herbals usually are inoffensive. They are, medication that don't bring a big problem, except when they interact with potent prescription medication. The medication that prescribed the doctor are potent, and they are okay at the doses that doctor prescribed. But if the herbal is considered like a weak acting, substance, is added to the action or interact with the prescription medication, then can become an issue. So the most common, probably you remember that from pharmacology and fundamentals. Medication that interact with the coagulation. Herbals that interact with the coagulation. Herbals that are weak, very weak blood thinners or anticoagulants, but very weak. Okay, that are the garlic, ginseng, ginger, and ginkgo, famously called the 4Gs. Garlic, ginseng, ginger, and ginkgo. Okay, but also vitamin E and omega-3 present in fish oil, all then has been tested. So what is the issue? Is bad to take fish oil omega-3? No. Vitamin E? No. Garlic or ginger? No. Yeah. Yuca con mojo? No. The issue is that if you are taking an anticoagulant, a potent blood thinner prescribed by the doctor, and or if you are going to surgery, then those herbals could bring problem. And obviously, if you go to surgery, you don't want to have a blood thinner in your body. And if you're taking warfarin, the dose that the doctors calculate is enough. If you add a medication that potentiates the warfarin, then you can start bleeding. Drugs, herbals that potentiate hypoglycemic drugs. The ginseng and oolong tea. This is frequently in Nclex. Okay, oolong tea is a tea frequently consumed by Asians that lowers a little the blood sugar. So they use that a lot for diabetes. Okay, so when they are diagnosed with diabetes, they use to drink oolong tea. But then if you are taking a potent hypoglycemic medication like a sulfonylurea, glipizide, glyburide, etc., and then you take oolong tea, then too much hypoglycemia, too much action decreasing blood sugar. Tested. One that probably you know. SSRIs are potent antidepressant medication prescribed by the psychiatrists and many physicians that elevate the concentration of the neurotransmitter serotonin in the body. And this improves the mood and is used for the treatment of depression. Monoaminoxidase inhibitors are rarely used nowadays. More frequently are used the SSRIs, but also could have a similar interaction. There is a herbal called St. John's wort. Okay, St. John's wort. Okay, this St. John's wort is used in teas or in tablets for depression, and has a mild stimulation of the production of serotonin. So the combination of St. John's wort with SSRIs could produce too much serotonin, and it is called serotonin syndrome. Serotonin syndrome is very bad. Serotonin syndrome produces something similar to the malignant hyperthermia, neuroleptic malignant syndrome, etc. Similar, not the same. And there is altered mental status, there is seizures, there are, hypertension, tachycardia, agitation, etc. And it could be very risky. So no combination of St. John's wort, neither with SSRIs or monoaminoxidase inhibitors. Remember that SSRIs are the fluoxetine, sertraline, paroxetine, citalopram, etc. Black cohosh, frequently consumed, especially in the rural areas, by women when have a perimenopause, climateric, or postmenopause symptoms like hot flashes. And it is an phytoestrogen, so an estrogen from plant that improve the symptoms of estrogen insufficiency. Echinacea. This is a medication super frequently consumed when the people have common colds at repetition, and then they think that they have a low immunity to stimulate their immunity. This kind of herbals are contraindicated in people with autoimmune diseases, in which you don't want to stimulate the immunity. By the contrary, the doctor will prescribe immune suppressors. So interact with immune suppressors, antagonize the action of the immune suppressor that the doctors are prescribing. Frequently testing Nclex. Know that you can have questions in OB how to deal with hyperemesis gravidarum, with the dry, salty crackers before getting up early in the morning, before getting out of bed. And ginger is a possibility. Ginger ale, ginger is a possibility. Valerian root. What you need to know, valerian root, frequently tested, is give somnolence. So is a herbal hypnotic medication. So give some somnolence. And if the client is prescribed a medication like a benzodiazepine, okay, for insomnia or for whatever, anxiety, and also combine that with valerian root, could be too much. Okay, I saw a question in Nclex in which the doctor prescribed a medication called trazodone. Okay, trazodone is one of the all antidepressant. Okay, the tetracycline antidepressants, similar to the tricyclic antidepressant like amitriptyline, that have a potent sedative, hypnotic, property. And trazodone is prescribed very frequently, for all people with insomnia. But then all people like these kind of herbals, and then they take valerian root together with trazodone, and then they can sleep too much. They can have a more than expected sedation. I saw this question, the interaction between trazodone and valerian root. The other one is this anticholinergic called hyoscyamine, that is anticholinergic. You know that anticholinergic medication produces dilation of the pupil, dry mouth, constipation, urinary retention. And in all people, anticholinergic medication can produce delirium, so alter mental status. Ephedra is also called mahuang. It is a herbal that is similar to epinephrine, so it's a sympathomimetic medication. And even they synthesize the ephedra in factories as pseudoephedrine. Pseudoephedrine, as I said, is a vasoconstrictor. It's a sympathomimetic medication. It's an adrenergic medication. It's a family of the adrenaline, used frequently for nasal congestion. Yeah. And of course, we know that the problem of the medication can produce tachycardia and hypertension. And if you combine, for example, MAO inhibitors, monoamine oxidase inhibitors, like phenelzine, with ephedra, the patient can present a hypertensive crisis. Sopalmeto basically is used for benign prostatic hypertrophy to improve the tendency to improve urinary flow in patients with benign prostatic hypertrophy. Also has been tested. For what is sopalmeto? How is the question? For the patient is taking black cohosh. What symptoms you expect the client to be presenting? And you see hot flashes. The patient is taking sopalmeto. Which symptom is what condition could have the patient? So they ask you your knowledge about this medication and when this herbal and when they interact with medication. There are many questions about insomnia in Nclex, for your information. And you need to know that in insomnia, is super important that the patient doesn't exercise after noon. So no exercising. Exercising in the morning is okay, but not exercising in the afternoon or the night is one of the most common. Second, having having the supper, having the dinner early, but consuming a small snack, a light snack before going to bed is good. And this snack should contain milk or dairy, because the component of the tryptophan and calcium favors falling asleep. Having a warm bath before bed can also help. Having the room cold, so in the cold side, they say it should be less than 70. Okay, 68 is the best. Okay, Fahrenheit. The best temperature. They say that is favors sleeping. So of course, cover yourself. Okay, wrap yourself in your blanket. And what else? Another that I saw was that apply. Okay. Avoidance of the blue light that have computers, telephones, and those how do you call that? Those electronic readings. Okay, those iPads, etc. to read. Okay, like Kindles, etc. That if they are used, should be placed in night mode to avoid the bright blue light, as it's called, the light that projects the electronics, that stimulate the pineal gland to inhibit the secretion of melatonin. That is the one that that they give you the. I saw specifically yogurt as a snacking question. Of course, who doesn't know that avoidance of caffeine, nicotine, and alcohol will help a person that is having insomnia? Yes. I saw a question about biofeedback. Biofeedback. You need to know what is biofeedback. Biofeedback is when you use a biological parameter like the pulse frequency or muscle contraction to guide your process of relaxation. So you can, maybe you are stressed and you want to relax. So you are going to start thinking in something that for you is relaxing. Could be praying, could be an image of a beach or something that is a pleasant for you. Could be, a relaxing music. And you are going to check your pulse. And then you are going to know that your thoughts are in the good track to relax you if you notice that your pulse starts, decreasing frequency. It is biofeedback. It's an example. So now that you know what is biofeedback, if you see that if it could be used to manage anxiety, that producing insomnia producing anxiety, of course, is good. And you know what is now biofeedback. Oxygen therapy, another topic that is frequent, and I want you to refresh. So don't forget that before initiating the oxygen, you need to elevate the head of the bed if the patient is in flat position. The flat position or the Trendelenburg position is not favorable to breathe. So obviously we commented that Trendelenburg is a no-no. A flat position is no good. Elevation of the head of the bed, at least a semi-Fowler, is good. If there is a severe distress, the right elevation should be high Fowler, so almost sitting in tripod position with the hands, supported by the floor or the mattress. Don't forget that oxygen can be toxic, and the amount of oxygen to be given is the amount needed to stabilize the client. Stabilization of a client who needs oxygen and is in acute distress is raising the O2 saturation around 90%. Professor, that 95% is the normal. Yes, but in a patient that is unstable, is critical with a shortness of oxygenation, elevating this O2 saturation in the range of 90 to 95 is acceptable. Makes sense? Independently of the COPD. COPD normally should be in this range all time. But in the case of the person that is not COPD, is this in the decompensated? The O2 saturation is 80%, very low. Elevating that to a range of 90 and 95, 90, 94 is acceptable. Giving more oxygen than needed is going to produce complications like dryness of the airway, atelectasis, pulmonary hypertension, and something called bronchopulmonary dysplasia, and in babies in premature retinopathy that can even produce blindness. So be aware that there is oxygen toxicity has been tested. You need to be in knowledge. It's more frequent, of course, in pediatrics. Know that because oxygen produces a serious desiccation or dryness in the nares and the airway, the nares, okay, the nostrils, should be lubricated with water-based lubricant. It is to warn you that never can be used petroleum, Vaseline, petroleum. And if the flow is equal or higher than 4 liters per minute, then it's better to provide humidifier, a humidified oxygen through a humidifier. A humidifier is a bottle that has stale water, and the oxygen is going to bubble here before going to the client. This is going to incorporate water vapor molecules mixed with the oxygen, will produce moisture of the airways. To administer oxygen, the first that you need to find is a manometer. You cannot administer oxygen without a manometer. This is a manometer. So there are questions in Nclex about if you know that. So if the doctor prescribed 5 liters per minute, 3 liters per minute, whatever liters per minute, the first that you need to find is a manometer that allows you to measure 3 to 4, 5, 6 liters per minute. And this is a manometer. This manometer is going to be attached, introduced, is a metal tube or pin that is going to enter in the wall outlet of the oxygen. You are supposed to be educated that there are 3 common outlets in the walls of a healthcare facility. One is green, is oxygen, and one is yellow, is air, just simple air, and the white is vacuum. If you don't know what is vacuum, what is needed to suction the trach of the client, you know. And for any use, any of those resources, you need to have a manometer. You say air. Air is used when you want pressure of air. For example, when you give a nebulization, when you nebulize albuterol or whatever with a nebulizer, a client, you do that with air. Okay, because if there is not need or ordering of oxygen, is not used the oxygen for nebulization. The oxygen is used for oxygenation, not for nebulization. The vacuum for suction. They ask you if you know the colors that identify those outlets. Because if the doctor orders, not always have this letter, okay? Not always have this letter that I'm bringing here. Only color without letters, okay? Without, signs, okay? So you are supposed to know by the color which one is oxygen, which one is air. Is as happened, I saw that in my practice with nursing here in America, I saw from certain frequencies that doctors order oxygen and the nurse introducing the manometer in the yellow outlet. So obviously it could be a knowledge deficit in the nurse about these details, which are important, because if the patient is receiving air, is not obtaining the benefit of the prescribed oxygen. And now you understand why this kind of stuff is tested in Nclex, okay? To make you understand that Nclex is a very comprehensive test to evaluate if the nurse is safe. A nurse that is using the yellow outlet for giving oxygen is not safe. Yes, you don't want a relative to be in this care by this nurse. So that's why it's tested in Nclex, okay? Remember that you have 2 main options to give oxygen therapy: nasal cannula, which is going to be in the majority of the cases, or a non-rebreather mask. Nasal cannula is useful until the rate of oxygen reaches 6 liters per minute. More than 6 liters per minute is not possible to be administered through nasal cannula. Remember that the doctor have infinite amount of liters per minute, but usually can reach around 15 liters per minute, okay? Usually it's less, okay? But the doctor can prescribe 8, 10 liters per minute, okay? So if the doctor prescribes more than 6 liters per minute, nasal cannula is not useful and need to be upgraded, upscaled to a non-rebreather mask. The nasal cannula is the most commonly used because it has the advantage that it's very comfortable. You have 2 prongs inside the nostrils, and it can produce trauma. But also the tube is threaded behind the ears. So you need to check the skin behind the ears. And as I said, the maximum is 6 liters per minute. And that's it. For the masks, you need to understand that now the nose of the client and the mouth of the client is going to be covered by the mask, and it's going to be tightly tight against the skin through this rubber band that is adjustable behind the head. It brings a safety issue. A mask is has some risk if the patient is unconscious. You can have an unconscious patient receiving oxygen and the patient vomits, because now the mask can fill with vomit, and now the patient will re-aspirate when breathing, because need to continue breathing, the vomit. And it's something to have in mind because it can be tested. This is one of the thoughts that can be avoided with elevation of the head of the bed, or minimized with elevation of the head of the bed. Remember that the amount of oxygen needed for a non-rebreather mask is whatever necessary flow in liters per minute to keep the bag half inflated during inspiration. Remember that what you have in the bag is only oxygen. Oxygen 100%. Yeah. And when the patient breathing incorporates this oxygen to the lungs. But the amount of oxygen flowing here in the bag should be enough as to prevent, to avoid the bag, the reservoir, from totally collapsing, totally emptying during inspiration. So always should be left half the bag filled with oxygen when the patient breathing. So if you notice that the bag is totally empty when breathing in, you are supposed independently to increase the flow in liters per minute until the bag is half inflated after inspiration. This is tested, and it is something a nurse must know. Don't forget that the incentive spirometer is to breathe in, and the steps to use this is frequently tested. Incentive spirometry is super important, that need to be taught to the client to be used properly. Always need to be used when the patient upright. And the patient will breathe in the air through the device. After the patient ends breathing in as much air as possible, then remove the device from the mouth and hold the air, a little, 5 seconds. Yeah. And is going to breathe out through the pursed lips without the device in the mouth, no? Through pursed lips until emptying the lungs, and then can do that again. Remember that the patient breathing through the device, breathe down through the pursed lips. They can, if they have wounds or pains, they can use a pillow to splint, to push, okay, a wound to prevent, stretching of the wound on the stitches, especially if the patient is going to cough, as usually is recommended to do after the use of the incentive spirometer. You are going to incentivize to introduce each time more and more air, elevating the marker that the client is going to use as a reference to increase the depth of the inspiration each time more and more. And the purpose of this is to prevent atelectasis and to prevent post-surgical or perioperative nosocomial pneumonia. Frequently tested. How frequent should a patient do that? 5 to 10 times per hour is tested. 5 to 10 times per hour. Okay. That's it. This is what you need to know about incentive spirometer. When I ask my student how to use this, many students ask the patient to blow, okay, and it is incorrect. If you have this option and you mark this option, you have the answer wrong. To breathe in. Suctioning is frequently tested, if you know the details. So remember that you need to determine if the patient needs suction. And they can ask you, select or apply, what the following elements are indication of suction of the patient. One is the presence of secretion. How you know the patient has secretions in the airways is because the patient has a sound called ronchi. Okay, the ronchi. Okay, ronchi is this gargling sound, like this gargle sounds that you know is no more than the presence of the secretions in the airway. The other way is that the patient, while having too much secretion in the lungs, will have a drop of the O2 sat, and the alarm of the O2 sat machine can go up. Another reason for suctioning is that the high pressure alarm of the ventilator can go off. The ventilator introduces air through the tube or tracheostomy of the client, no, to the lung. And of course, it's going to find a resistance, it's going to find a pressure. There is a limit for the increased resistance of pressure that the machine should encounter, find. If there are many secretions here in the airway and the bronchi, then the machine will find more resistance, more opposition to the introduction of the air, and will need to generate more and more pressure to be able to introduce the air. And for that reason, the high pressure alarm can go off, and it is an indication that maybe the cause is secretion. To have suctioning, you need to first identify the patient needs the suction. You don't suction around the clock. You suction only when the patient needs suction, an important concept. To suctioning a client, after you bring your equipment and you prepare your equipment, you wash your hands, you position the client, okay, as high as tolerated. After positioning the client, you are going to set the wall suction pressure, that is, as I said before, this white vacuum that you see here, yes? And you are going to set the pressure more or less the blood pressure, no, more or less the blood pressure, okay, less than 120, yes? And you are going to hyperoxygenate the client, placing oxygen in the tracheostomy of the tube before suctioning. The nurse will have two conditions for hands. One hand is sterile and the other hand is clean. The hand that is sterile should be the dominant hand. It is tested which hand you keep sterile for procedures in which one hand will be sterile and the other hand is going to be clean. For example, to introduce a Foley catheter, one hand is sterile, has a sterile gloves, the other hand is clean. The dominant hand should be the sterile. The dominant hand should be grabbing, holding, taking the sterile Foley catheter, while the clean hand is separating the labia or holding the penis of the client. Labia is the woman, penis is a man. Okay, so this other non-dominant hand is clean, separating the labia. Once you touch the labia, your hand is not sterile anymore. But the hand that is going to hold the Foley catheter is going to be sterile. The same happens here. One hand, the dominant, is going to be holding the sterile catheter that is going to be introduced inside the trachea. The other hand is manipulating the pressure. The other hand is grabbing the tube for the T-tube for oxygen and removing the tube, etc., etc. And is holding the hole that need to be intermittently or continuously pressured. Okay, and then having this dominant hand, you know, grabbing or holding this sterile catheter, you introduce without suctioning. So there is a hole that need to be opened, is not occluded by the thumb of the non-dominant hands while introducing the sterile catheter inside the tube or the tracheostomy. Once you find resistance, it's because you are in touching the carina, okay? And then you withdraw. Carina is the fork that makes the trachea to produce the two main bronchi. And then you withdraw half an inch, 1 centimeter. And then you start suctioning the client. They're not going to ask you if the suction is intermittent or continuous because the new evidence says that it is not important, okay? Even they favor, the evidence favors the continuous suctioning instead of intermittent. Go to the literature or daily literature to find what, but you can do that intermittently or continuous suctioning with a circular movement while withdrawing the catheter. Limit this time to 10 seconds. What Nclex has said is 10 seconds, no more than 10 seconds, okay, suctioning, because, you know, it's the maximum that can tolerate the usual patient that has a tube. And don't forget, after you suction the trachea, which is the first that you do, you can go with the same catheter to non-sterile area, like the mouth, the nose, etc. But you cannot go back, or you cannot do that the way around, the other way around. So first the trachea that is sterile, and then the non-sterile area that are the mouth, the nose, etc. Okay, and after you suction is when you do tracheostomy care. The tracheostomy care is when you remove the inner cannula of a tracheostomy and replace that with a disposable one, or you clean that, okay, and with a sterile normal saline, and reintroduce the cannula. You clean around with normal saline the ostomy, the hole, and place, okay, gas, but don't cut the gas because it's going to produce lint that can be aspirated. In clients that are in ICU with endotracheal tube, nowadays the catheter is permanently attached to the tube inside a sleeve, a plastic sleeve that keep the catheter all time sterile. For questions about the closed drainage system for chest tube, remember that you have two chambers. You have three chambers. One chamber is called collection chamber, collecting chamber, collecting chamber. That what collects money? No, collects, collects liquid. If there is liquid in the pleural space. In the pleural space can be liquid. It's called pleural effusion. And it could be an indication of chest tube. Thoracentesis or chest tube. Thoracentesis with the needle, and then my students should know. Well, yes, when I touch concept 2. I don't know if there are any concept 2 student new here. The video where the provider is suctioning with a needle, or a introduction of the chest tube, that in this case is when must be connected to a closed drainage system, which is represented there. Okay, so the first is called collecting tube and collect liquid, and that's it. Your only issue with this collecting chamber is one: if what is coming is bright red and in abundance. Abundance says your book, the Nativicius, says 70 milliliters per hour, but it's not. It is never seen that before. Bright red, bleeding. Call the doctor, inform the doctor patient is bleeding. And the other issue about this collecting chamber that I think, if you can identify here, which one is the collecting chamber. In Nclex, you don't have this sign here, okay? And then you need to say all this is the collection chamber. All this is where the liquid start accumulating in those cylinders that you see here, in those cylinders. what else they can ask you? If you know how to count, as simple as that. So suppose that they just a second, highlighter in what color? Red. Suppose that they say when you arrive, okay, the level of the liquid is here. And when you leave, okay, the level of the liquid is, let's see, here. Okay, so in your shift, you arrive here, no? You arrive here, yeah, and you live here. How many milliliters drain the client? You say, oh my goodness, here I see that go from 140 to 160, which is here, no? But 140 to 160 is going to be 20, yeah? But I have a little more. I have another line over 160 mark. So how much is going to value each line? So I have 50 into 60 are 10. I have 2, 4, 6, 8, 10. Okay, it's going to value 2 each one. So it's going to be 22 milliliters. And did you understand my explanation? Okay. So this, if you don't understand, tell me, okay? This is a question that I see in English. You need to be careful because the value of each one of those lines is different. For example, here, go from 900 to 150. So you have the 1, 2, 3, 4, 5 spaces, no? For line 3, 5 spaces. So obviously, each line is going to weigh 10. Here is weighing 2. Here is weighing 10. So you need to know how much weighs each one of the lines. It applies for syringes. You can have questions of syringes, etc. It's just knowing the division, the gradation, you know, the value of this when it is increasing in different ways. Okay. The other is the water seal. Usually it's called water seal. Sorry, this program is faulty. Let me just a moment, guys. Result inside. Let me discard. Just a moment, guys. Show. No. Okay, this is much better. So you can see the PowerPoint, no? No problem. Can you see the PowerPoint?
Yes.
Yes.
Okay. Not to be sure. So the other is the water seal. Okay, the water seal. It's called water seal because all we have water, and it's like a valve. It's like a seal that allows the air to leave but not to enter. So necessarily here you must have, okay, the tube underwater, and you must see the water going up until certain moment, until certain limit, sorry, going up until certain limit when the patient is breathing in. But then you need to see the water coming down when the patient is breathing out. So you see the water going up, and then going down. And you see this fluctuation. Normally while the patient is breathing. So the water need to be going up and down, going up and down, up and down. And when the water is coming down, at the end of the expiration or breathing down, when the water comes down, you see bubbling. So this bubbling must be intermittent, cannot be continuous. So summarizing, you see a movement of the water, the column of water inside the tube going up and down, coincident with the respiration of the client. Breathing in, ascends. Breathing out, descends. And at the end of the moment of descending the column of liquid, you see a bubbling of air there. So it's an intermittent bubbling of air. The problem that you have here is that this bubbling could be continuous. If the bubbling is continuous, because there is a loose connection in any part. So there is something that is broken or loose in the connection. And you need to know that you need to be checking the system to correct the leak of air that is entering. If you don't see more bubbling of air coming out and the patient auscultation is normal, then you assume there is no more air inside the pleural cavity and the lungs are totally expanded. So how you know that lungs are totally expanded, how you suspect that lungs are totally expanded, because you don't see more air bubbling here while the patient breathes. And you auscultate, normal, lung sounds. Of course, you report to the doctor. Doctor will order an X-ray and verify that the lungs is totally expanded, and then probably will order or will come to remove the chest tube. In the third chamber, you need to have water, and you see, a continuous bubbling, but it is not tested. This is rarely tested. This suction chamber is doesn't need to be connected to wall suction all the time. The patient can ambulate. The patient can be ambulated with this, holding with the arm, with the hand, this box. As far as this box is kept below the level of the chest, okay, the patient can ambulate. It's the only recommendation they need to give. If the patient wants to ambulate, you disconnect from wall suction, allow the patient to ambulate, but the patient or the CNA or yourself is holding this box below the level of the chest, period. And in this box is here where you see the liquid ascending and descending, and in this area is where you see the bubbling. The suction is regulated here, but it is rarely tested. So all this is the collecting chamber, the collection chamber. Here you see the water seal, and here is where there is suction that could be connected to the wall suction. The accidents that can occur are two types. You can have an accident in which tube, this tube can be disconnected. Okay, could be disconnected, okay. They can become disconnected. If those tubes become disconnected, the first that you need to do is to introduce this tube that is hanging there, okay, be introduced inside a bottle with a sterile whatever, sterile water or normal saline. So it is going to be submerged underwater. It is, meanwhile, you are going to be holding this with your hands. No, you are going to be holding this bottle with your hands, keeping this tube introduced inside. Okay, introduced inside the bottle. Okay, so it is meanwhile a new equipment, a new box is prepared to reconnect this tube to a new, drainage system. ¿De acuerdo? So it is what you need to know about if it is this connection. You need to introduce in a water. Okay. in the world. Yeah, that's it. The other possibility is that this tube, okay, this tube, the chest tube, is dislodged, leaving what? Leaving a hole in the chest wall. In this case, you need to take a non-porous gauze, okay, and covered the hole. And you are going to tape only 3 sides. 1, 2, and 3. That's it. Those are the classical, okay, questions about chest tube. No problem with that. You can be asked how to introduce the step, place in order the step to introduce a nasogastric tube. So after you have the order, you gather your equipment. Before going to the room, you gather your equipment. Yes. And when you enter the room, you identify yourself, and then you identify the patient. Before explaining anything to the patient, you identify the patient. If this is a correct patient, then you explain the procedure. This sequence is the same for all the procedures. So first, check for the order to do the procedure. Second, gather your equipment that is stored in a stock and go to the client's room. Tell the client who you are, so introduce yourself. Then identify the client. Once you are sure that this is the correct client, then explain the procedure to the client. Now, usually the next step in the procedure is to position the client. So one of the first steps in any procedure is to place the client in the adequate position. It implies one, elevation of the bed, all the bed, to your comfortable position for your work. So body mechanics, ergonomics. And second, position the patient in the position that is going to be more comfortable for the client. When you place the client in this correct position for the procedure, remember to protect the client's linen. I mean, if you are going to get a vein, so insert a peripheral venous action device, if you are going to give an enema, if you are going to offer bedpan, if you are going to suction the client, if you are going to do wound care, any procedure you anticipate that you can soil the linen of the bed, and you can avoid that from happening. Protect the linen with, with a pad, with a shock, with any, protection, a towel, any protection that is needed. Because I saw that, and then you need to know in which moment you do that. At the moment of positioning the client, you protect also the linen. So I repeat, check for the order for the procedure, gather your material, introduce yourself, identify the client, and then position the bed, position the client, include the protection of the linen. Now everything is ready to do the procedure. So now each procedure will be different. The previous steps are common to most of the procedure. And if they are included in how to place them in order, in which order are going to be. In the case of the introduction of nasogastric tube, the next step is to measure how much of the tube is going to be introduced in the client. For that reason, you need to know, it's tested, that you need to measure from the nose, from the nostril, from the nose to the ear, and from the ear to the xiphoid, okay, process. So if you have a person, okay, okay, you need, okay, to measure, suppose that here is the sternum and the xiphoid process, okay? The xiphoid process of the sternum, yeah? Okay, you are going to measure the tube from the nostrils to the, oh, I forgot to draw the ear. Okay, from the nostril to the ear, and then to the ear to the xiphoid process. And then this is the remaining tube. So you mark here all the tube that is going to be introduced. This is all the tube that is going to be introduced. Yeah, very well. So this is important. And then when it is measured, you lubricate before introducing with water-based lubricant, never petroleum. To introduce the tube, of course, you need, okay, you need to find the nostril, into the tube in the nostril. But then while you advance the tube through the nasal cavity toward the throat, you know, with a continuous, but, you know, with a careful, you know, movement, you ask the client to flex the neck. So tuck the chin on chest. If you extend the neck, the tube will go to the trachea. If you flex the neck, the tube will go to the esophagus. While introducing the throat, the tube asks the client to swallow. You can give chips or eye chips, or chips, eye chips, or let's just say that potato chips. Okay, the eye chips in a sip of water to swallow. It is important that if the client starts choking, you remove the tube a little without totally, you know, withdrawing out, okay, the tube. Just remove a little until the patient stops coughing and choking until it stabilizes, and then you attempt again, being sure that the patient is flexing as much as possible the tube. Once you find the mark and is introduced, you secure the tube with tape to the nose, make it an X-ray, and then you know, you can document what you did. Okay, each time you fit in the future introduce something there, check for placement, okay, with the pH. If you have a patient with a nasogastric tube connected to nasogastric suction, it's because they are using this tube, which is called saline sump. So remember the saline sump, this is connected to the suction machine. And this suctioning generally is intermittent. But this blue tail, short tail, the big tail of the tube is for air to enter, is a air vent, and only air can enter here. The other concept that has been tested is how to remove the tube. So put in order the steps to remove the tube. What you need to know about this tube that is inside the person, okay? The tube is in the gastric cavity of the client. And inside the tube, because in the gastric cavity there is a content, there is liquid. There is liquid inside the tube because it is inside the stomach. And in the stomach, you have liquid, okay? This liquid is acid, blah, 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 yeah? Don't forget that in front of the esophagus, you have the trachea. You have the trachea. When you remove the tube out, you remove the tube, there is a risk of having this liquid dripping in front of the trachea and having aspiration. For that reason, you are going to take a syringe and connect the syringe, okay, to the tube. And you are going to introduce a couple of milliliters of air to what? To push this to push this liquid out and have the tube empty with only air. Yeah, so that's why the syringe. Okay, so going back, once that you decide to do the removal of the tube, the first that you are going to do is to disconnect the tube from the suction. So you disconnect the tube from the suction, and after you disconnect from the suction, you remove the tape that was securing the tube to the nose. You remove this tape. Okay, you remove this tape, and then you connect with the syringe. You connect with the syringe to introduce the air and remove the air, and then you pinch with your finger the tube. Okay, so there is no way of more liquid entering the tube. Ask the client to bear down, to do Valsalva, okay, bear down, and then you remove the tube. So this is the order, and then at the end you document the procedure. So summarizing, what is the important detail that you need to know at the moment of removing a nasogastric tube? That you need to take the precaution of preventing aspiration while you remove the tube, because the tube has liquid inside and will be dripping as you pull that and pass through the entrance of the trachea. And you avoid that introducing air first in the tube, asking the patient to bear down to avoid breathing in while removing the tube, and removing the tube. For Foley insertion, what questions you have in Foley insertion? Well, in Foley insertion, you know that the steps, okay, aquí are mentioned, and you know the story of the dominant hands and non-dominant hands, keeping clean, etc. There are some details that I want to discuss before going to the steps of the procedure. First, when you introduce a Foley, in males or females, you are in the moment that the tip of the Foley enters in the urinary bladder, you see urine coming out in the other stream, in the other side. Please don't consider that all the Foley is inside the bladder in this moment. You need to push, you need to introduce 1 inch or 1.5 inch more deeper the tube before inflating the balloon. If you consider, when you see the urine that is already in position, then you inflate the balloon inside the urethra and it's going to produce unnecessary trauma. To introduce the Foley in males, you need to elevate the penis between 60 to 90 degrees. So the penis, normally flaccid penis is hanging there, so you need to grab with your non-dominant hand the penis, and after cleaning, you are keeping the penis, okay, between 60 to 90 degrees, okay, of elevation. And then you introduce the catheter in this way. This is going to straighten up the urethra, preventing the flexure, okay, the curve that makes the urethra when the penis is flaccid, and avoid trauma. Don't forget that after you introduce the Foley in males, because it's frequently tested, you need to return the foreskin into the rest position, covering the glands. In females, the most common situation is that when you introduce the Foley, you don't obtain urine. It means that the Foley is in the vagina here behind. Okay, so you miss the urethra. What you do without is important, without releasing the opening of the labia, keeping the labia open with your non-dominant hands, you request another sterile catheter, and then you go above the Foley that failed to find the urethra. So you leave the Foley, you leave the Foley here, you leave the Foley here, okay? You leave the Foley that fails here, and then with the new Foley, you go above that, okay? after you obtain urine and you secure the second Foley, then is when you remove the failed Foley. Those are classical questions. For Foley insertion, okay, so check the orders, gather your material, introduce yourself, identify the patient, okay? Of course, you are going to don sterile gloves after you prepare your equipment. So you assume that before donning gloves, you need to wash your hands. Okay, so you wash your hands and you don sterile gloves. So there are some procedures in which you don't need to use sterile gloves, and there are procedures in you just need to use sterile gloves. For example, for trach suction and for Foley insertion, you need to use sterile glove because you are going to be holding, you are going to be grabbing the catheter, the sterile catheter with your hand. But for example, to introduce a peripheral venous access device, no, a peripheral catheter, you don't need to use sterile gloves. Why? Because you don't touch the catheter. You only grab the base of the needle that is held there with a clean glove. But the tip of the catheter, the tip of the needle, the tip of the needle, the tip of the needle, and the catheter is over the needle is not touched by you. That's why you don't need to use a sterile gloves to introduce a peripheral venous access device. To irrigate a wound, which is sterile, you use a sterile normal saline, and you use a sterile syringe. But you don't need to wear sterile gloves. Why? Because in any moment, you need to touch inside the wound to irrigate, or you need to touch the tip of the syringe with, you are grabbing the syringe in the part that can be a non-sterile, because it's still inside, and you push the plunger to irrigate the wound, you know, and you use applicators, you use applicators to apply medications or forceps to apply the gases. So, for example, to remove a dressing, you don't need to use sterile gloves because you are going to be holding the dressing, which is clean, is not sterile, and being removed. For the same for an enema, and the same for the introduction of a nasogastric tube that are non-sterile areas. But the two sterile areas that you need to remember, you need to wear sterile gloves, is to introduce a Foley catheter and to suction the trachea. In the case of doing the dressing change of a central catheter, first you wear clean gloves to remove the old dressing, but then you need to wear sterile glove. Why? Because you are going to be holding the catheter while you wipe the catheter that is under the dressing and while you clean the area. So it's another example of when you need to wear it. Okay, they ask you if you know when to use a sterile glove, and if it is going to be only one hand still, which hand is used, etc., etc. You're supposed to know that. Okay, so going back after this explanation, because all this come to my mind, but many questions that recently have been in Nclex, students discussing those questions with me when they discuss their Nclex with me. And it's important that I, clarify those topics before you go to the Nclex. So you're going to be wearing sterile gloves, as we said. So now with having a sterile glove, you are going to grab the catheter and you lubricate the tip of the catheter. No problem, because you are sterile. You lubricate the tip of the catheter and you leave the catheter there in a sterile surface. Okay, with the syringe, the sterile syringe, with a sterile normal saline attached to the port of the catheter that takes you to the balloon and is to inflate the balloon. So this is the Foley you already prepared. So now is when you are going to discriminate which hand is going to be sterile and which hand is going to be clean. The non-dominant hand is going to touch the labia of the clients and will, if it's a woman, or the penis of the clients, to keep it in 60 to 90 degrees elevation and to retract the foreskin. In case of a woman, to separate the labia. So in this moment, this hand is not sterile anymore because you already touch normal flora. And with your dominant hand, which is sterile, you are going to hold an applicator, okay, an applicator that in the base where you are holding it is sterile, but in the tip has a sponge with an antiseptic. And with this antiseptic, where you are doing the cleaning of the urethra of the client. Remember that in man, the cleaning needs to be in circular movement from the urethra away 3 times. Yes, but in women is different. In women, you are going to have 3 times, but you first are going to go from front to back only once. Front to back only once without returning. Okay, right labia, another applicator. Okay, front to back only once, left labia, another applicator, front to back, center, going over the urethra. This is the way of cleaning the genitals of a woman. Keeping the labia separated at all times. Now you didn't contaminate your hands because you were holding applicators to clean the client. You grab the Foley and then you introduce the Foley. Yeah. When you see urine coming, you advance 1 inch more. And then is when finally you can lose the labia or the penis of the client. And then you hold with your non-dominant hands, with your clean hands, your contaminated hand, you hold the catheter. Why you can hold now the catheter? Because this catheter is outside the urethra and is not going to enter inside the urethra. It's already until there is not going to advance more. And then with the dominant hands, you inject, okay, the normal saline in the balloon to inflate the balloon. And now it's fixed, and then you fix that, you secure that in the thigh of the clients, and you clean the client, remove the protection, the shock, lower the bed, and document. Removing the Foley, remember that the most important is to empty the balloon. So again, you are going to check the order, do all the stuff. The only thing that you're going to use is a pad to protect the client, a pair of clean gloves, no sterile glove, because you are going to be holding the Foley outside the urethra, and you are going to pull the Foley from outside the urethra. So you don't need to wear clean gloves. And a sterile glove. You are going to be wearing clean gloves. You don't need to use sterile gloves. And then with a syringe, doesn't need to be sterile, but they come sterile. You are going to suck the water. You connect that to the port of the balloon, suck, okay, the water to deflate the balloon. And then you ask the client to take a deep breath and you pull continuously, gently but continuously, the Foley out. Previously, you put a pad to protect the linen. You wipe, okay, the genitals of the clients, and then remove the pad and document. Remember that all those procedure fundamentals are tested in Nclex. For taking a specimen of urine, remember that you need you use clean gloves. Clean gloves. You don't need to use sterile gloves, but you are going to have a sterile syringe. You need to clean the port with alcohol and allow to dry. And you need to clamp, as you see here, the tubing, not the Foley, the tubing that goes to the back. You need to clamp that for 15, 20 minutes to allow the urine to accumulate here. So now urine accumulate here because it's clamped. And then you come back with your sterile syringe, but with clean gloves. And then without touching the tip of the syringe, nor touching neither touching the tip of the syringe nor touching the port that have already cleaned with alcohol, you connect the syringe and you suck the urine. Don't forget to unclamp after doing that. In a clean catch, the clean catch is soap and water. So the genital of the clients are clean with soap and water. A regular perineal care can be done by the own client if it's competent, or by the CNA. And then you ask the client to start peeing, and the first part of the string is going to the toilet, is going to be discarded, okay? Then the mid of the string, so the middle of the string, is going to be collected in a steel container. Never touch inside the container or touch the lid from inside. Don't put your finger inside. So put the lid upside down, okay, on the surface, and then grab the lid through this and cover the container and send that to the lab. For continuous bladder irrigation, remember that the liquid is entering, wash the bladder, and leave. But also the client urine is going to be, from the kidneys, are going to be gathering here and added to this bag. The desired outcome is to have a pink liquid coming out. No dark red, no white, but pink. And this is the way that is going to be regulated, the drip of the irrigation. And remember that you are going to have frequently the calculation in which you have to calculate the urinary output, subtracting the amount of irrigation liquid that enters, okay, in your chief from the amount of liquid that is in the bag. So if in the bag you have in your chief 1,500 milliliters, and you introduce 1,000 milliliters in the irrigation, the different 500, it is the urinary output. And don't forget that there is a possibility of producing dilutional hyponatremia in those clients if the irrigation solution is hypotonic, and you need to monitor for alteration of the level of consciousness. For enemas and ostomies, also they ask you to set the step to doing those procedures. For enemas, remember that it's a Sims position, and Sims position is always left lateral. And as a consequence, if you have a left lateral, the upper leg is the right leg that should be flexed. The amount of the length of the cannula that is introduced is tested. 3 to 4 inches, okay, inches. You need to measure, okay, how much cannula is introduced inside the rectum, because need to be deep enough as to avoid the flow of water backflowing instead of entering in the colon. 3 to 4 inches. The cleansing enema is tap water, can be between 5 to 1,000 milliliters of warm solution. Don't introduce too cold because it's going to be painful. This is another detail, how much you elevate the bag, because you have the client, you have the client, okay? The client is resting in Sims position, okay? Okay, in Sims position, and you need to have the bag higher than the patient. So by gravity, the liquid is entering in the column. Yeah. So this is the height of the bag. The height. This height need to be between 12 to 18 inches, 1 to 1.5 foot. Yes, 12 to 18 inches, also tested. What happens if the patient is having too much cramp? colics when the water is entering? Well, you have different options in the question. One option could be clamp, so stop any entrance of liquid until the cramps improve and then restart the introduction of the liquid, but at a lower height. And the other is just lower the height of the higher that you put the bag, the faster the liquid should be entering. This liquid should be entered in 10 to 15 minutes. If the liquid enters, this volume of liquid enters too fast, the patient won't tolerate the procedure because cramps, abdominal cramps, colics, pain. You need to ask the client to hold for 1 or 2 minutes. If the client cannot hold more, then you need to see the clients in the toilet. Please take care of not giving more than 3 cleansing enemas in a client, because more than that can produce water retention. Know the difference between cleansing enema, which is to introduce the water and then immediately allowing the water to leave with the feces, versus retention enemas. Retention enemas are a small amount of liquid, no more than 100 milliliters, that need to be retained so the patient cannot poo after receiving the enema. One of the most famous retention enemas that are tested in Nclex is the sodium polyestyrene. Sodium polyestyrene, also known brand name K-xalate, is this resin that lowers the potassium when administered in enemas. Yes, tap water enemas can be delegated to the CNA. The CNA can administer tap water enema under your supervision, but tap water only, no medication. And for suppositories, okay, remember this suppository need to be cold. Suppositories are made with a material that at room temperature or body temperature melts, releasing the medication. If the suppository is not cold, then it's going to be soft and could not be introduced in the anal canal. So the suppository is going to be cold. It's going to be lubricated with water-based lubricant and should be introduced with clean gloves, of course, until going beyond, okay, of the sphincter, usually 1 inch or 1.5 inch beyond the sphincter. The steps to change a bag of colostomy, remove the old one. All these procedures are clean, not sterile. Remove the old pouch, clean with warm water and pat dry. It's expected that the stump have little bleeding, is no problem. Measure the stomach, do your assessment, measure the stomach, cut the wafer, the base of the new bag to the adequate size, leaving only 3 millimeters separation between the base, this is the base with the sticker that you are going to cut with the size and the shape of the stomach, and here comes the stomach, no? And here comes the stomach. So no more than 3 millimeters separation between the hole that you cut and the border of the stomach. Apply skin barrier, apply the base and push, and then apply the back that is clicked to the base. Close with the clamp, okay, the opening of the back, and document. You can delegate this to the LPN, and you can delegate to the CNA. They change the back, but not cutting the wafer. Assisted devices. Remember that for crutches, the most important is to avoid the trauma of the armpits, the nerve of the armpits, the axillary plexus, keeping a separation between the top of the crutches and the armpit, the axilla. So 3 fingers with separation, 3 centimeters, 1.5 inch, 2 inches separation between the axilla and the top. The way of wearing the those devices is the tripod position. So it means tripod. Okay, the tip of the crutches are going to be in front and lateral of the feet, separated, okay, separated from the feet. And the patient should not lean on the crutches because this is going to imply that it's pushing in the armpit with the crutches. Going upstairs, remember that the good leg go first. If you have problem of memory, remember that heaven is up and good people go to heaven. So ascend to heaven. So going up, the good leg goes first. But going down, remember the hell is down there, and bad people go to hell. And remember that the bad leg goes first. But before going the bad leg to the lower step, the client should be placed the crutches. I mean, if this is the step and the client has a good leg, which is green, and a bad leg that is red, yes, and also had the two crutches that are black, yes. So going down, first go the two crutches, and then the bad leg, and last the good leg. This is the way of descending in this way. Trying to remember those details because it's very easy to remember. For when you are using crutches and you want to sit in a chair, must be a chair that must have arm. So it need to be an armchair, an armchair. And when the client is approaching backward, okay, the client is going to hold the two crutches. The two crutches are going to be held together in the weak side, while the strong side hand is holding the arm, and then is going to sit, and the same to stand.
Tú subes con la buena, bajas con la mala.
Arriba con Dios, para abajo con el diablo.
Okay.
Mira si está alborotada tu hija.
Hello. Hello. Okay, now we are good. Okay, cane. Probably cane is the most commonly tested. Important with cane, you need to teach the client to hold the cane in the strong side. So the cane cannot be in the same side of the weak leg. Cane opposite to affected leg. It is a mnemonic hold. Second, cane will do the same as the weak leg. So if you have a weak leg, okay, a weak leg. Let's see this is the foot that is weak, and you are advancing. So your strong foot is on the air because you are walking. In this moment, the cane need to be on the floor, helping the weak leg. But then when finally the good leg, the good foot is on the floor, and the one that is advancing, the one that is in the air advancing is the weak leg, because this is the way that you walk. You elevate one leg, advance, and then you walk this way, no? The cane will be on the air, also advancing with the weak leg. That's it. This is what you need to remember. And the other topic is this. Where should be the top of the cane? Where should be the top of the cane? And is in the hip, where the great trochanter is, in the hip. Okay, this is the adequate height of the cane. When the crutches, both crutches and canes, is in the adequate height, the elbow of the client is found. So this is the hand grabbing the cane. The elbow is going to be found having a 30 degrees angle. It's a constant in this stuff. okay? And when you are walking a client with a weak side, please be always helping the client in the weak side. So if the client with the weak side is falling, is going to be falling toward you, not away of you. And you can hold the client and slide the client to the floor. If the client, if you are in the strong side and the client is falling away of you, you are going to fall together with the client. So summarizing, you need to be placing yourself in the weak side of the client. Observe this picture that this person has a weak side that is this. This is the weak side. Sorry, no, I'm sorry, I'm saying disparate. Is this the weak side. And that's why is holding the cane in the strong side, is holding the cane in the strong side, the strong side. That's why the cane is held in the strong side, and the person that is helping the client is in the weak side. When you have a patient that is going from bed to wheelchair, place the wheelchair, please place the wheelchair, okay, in the strong side of the client. So if the client has a strong side, okay, and is sitting here, has a strong side, the client has a strong side, and has a weak side, okay, a weak side that is red. Please place the chair toward the strong side. So when the patient is getting out, can help holding the arm of the chair with a strong arm. This is the rationale, so you will never forget. Okay? All those are being the details of this ergonomic that I see in English. I don't know you, but those are areas that are frequently forgotten, and this is foundations. Yeah, you cannot demonstrate ignorance in those areas because those are part of the foundations of nursing, and that's why I wanted to refresh that with you. Okay, so let's do a page of questions. Okay, the nurse is evaluating a client taking quetiapine. Who knows what is quetiapine? So here comes the challenge. This is the way that Nclex make the pharmacology questions. They don't mention, or very rarely, the family of the medication. They mention a medication, a commonly used medication. But now comes, this is the challenge. Thanks God, guys, don't be scared. Pharmacology questions are not common in English. It says it is less than 15% of the test, probably much less, and much more easier than this. But you are supposed to know that what is quetiapine. Quetiapine is one of the most commonly used ¿cómo se llama? A typical antipsychotic medication. So you are supposed to memorize, make a flashcard of the most important group of medication with their representatives, because it's the way that Nclex is going to be tested. So you need to know, for example, for the antipsychotic, you need to know the haloperidol. This is something that probably you know. It is the old antipsychotic medication, the one that can produce more adverse effects, EPS, malignant, ¿cómo se llama eso? Neuroleptic malignant syndrome, etc. Tardive dyskinesia, akathisia, acute dystonia, Parkinsonism, neuroleptic malignant syndrome, etc. But you have new antipsychotics that are used more frequently. And you have the most important to remember, clozapine. Because what the first, and is super frequently tested because it has a very specific adverse effect, can produce depression of the bone marrow, causing leukopenia, neutropenia, a granulocytosis that maybe you heard before. And you need to remember that. As a consequence, any psychiatric patient taking clozapine need to be having periodic CBC count, okay, to see how are the white blood cells. The other one that I see frequently in Nclex mentioned as medication is risperidone. Risperidone. Okay. The other one is this, quetiapine. At least, please. There are many others. Okay, aripiprazole, etc., etc. But please, at least trying to identify these 4 medications by name as antipsychotic medication. Okay, so now you are getting the idea of what is going to be your challenge in Nclex, in relation with the pharmacology. Okay, for example, when they want to ask you a question of the risk of GI bleeding in patient taking NSAIDs, they don't mention NSAID. They say indomethacin. They say ketorolac. The most difficult that I've seen is ketorolac, because I know that many of you don't know that those medications are NSAID, ketorolac and meloxicam. They say ibuprofen, they say naproxen, they say even indomethacin, maybe diclofenac, okay? Okay, but the one that most difficult that I see, the people have more problem relating NSAIDs with the names is ketorolac and meloxicam. So, and now it is going to be a very easy question because the patient is receiving meloxicam, okay? Is receiving meloxicam or receiving ketorolac. What is the most important, adverse effect? GI bleeding. So that's it. So let's go back to the question. The client is Vallin quetiapine, which finally required priority intervention and report. Jaw contraction with reducible tone protrusion, sedation with impaired gait, fever and tachycardia, restlessness and suicidal threats. Maybe by instinct, you say, oh my goodness, if you apply Maslow here, okay, fever and tachycardia is a physiological disturbance and should be the priority. Maybe by instant you say, oh my goodness, because the symptoms, restlessness, suicidal threats, okay, sedation, impaired gait, okay, dystonia, jaw contractions and reducible tone protrusion is an acute dystonia, 1 EPS. It must be an antipsychotic medication. This is the way that you can deal. If you have this question in your Nclex, you don't have any idea what's quetiapine. Okay, and maybe by using your common sense, etc., you can. But once that I'm telling you, it is an antipsychotic. Which one is the worst adverse effect of an antipsychotic medication? The one that can kill the client.
Sí. Suicidal.
But what? The antipsychotic medication is not causing suicidal threat, suicidal ideation. You need to know that there is
malignant syndrome.
Exactly. This is the one that I want you to have in mind. That in psychotic, what is a psychotic client? It's a patient that has schizophrenia, okay, is a patient with schizophrenia or a maniac, okay, mania in crisis, ¿sí? It's a patient that is a cuco, está de amarrarlo, ¿ya? And those patients receive antipsychotic medication, okay? Psychotic. Those patients are not frequently, the most frequently suicidal. Okay, the most frequently suicidal are the depressed client. Okay, the problem here is that these antipsychotic medication that are not necessarily producing psychotic suicidal ideation produce something called neuroleptic malignant syndrome, and it's like the highest emergency in antipsychotic medication, because the patient can die quickly. It's one of those syndromes that I said that can be rhabdomyolysis and seizures and blah, 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 blah. And is characterized by fever. So each time you have a client taking antipsychotic medication, has fever, rigidity, hypertension, tachycardia, think in neuroleptic malignant syndrome. And probably the most important is fever. It's a patient that has not infection. It's a patient that is developing the fever because the neuroleptic malignant syndrome. It's very similar to the malignant hyperthermia that appears with anesthetics, and also very similar to the serotonin syndrome that I mentioned before, that happens with the combination of SSRIs, the antidepressant medication, no antipsychotic, SSRIs, and St. John wort. So you need to try to have this concept clear, because we'll help you. Yes, what is the purpose of this question? To evaluate if the nurse is aware that a client receiving antipsychotic medication can develop, very rarely, but it can develop a catastrophic, severe, potentially lethal complication, adverse effect, which is called neuroleptic malignant syndrome. That is characterized mainly by fever. Fever, rigidity, hypertension, tachycardia, altered mental status. Evolve quickly to a lethal condition. It is true, you are right in saying suicidal is an emergency in psych. Yes, I agree with you. You're right, totally right. But the patients that have quetiapine are not the classical patient that has suicidal risk. If the question say, instead of quetiapine, says fluoxetine, okay, say fluoxetine. Okay, fluoxetine, okay. This is what is fluoxetine. Fluoxetine is an antidepressant. So what means that the client is taking an antidepressant, the patient is depressed. And it is known that in the first period of taking antidepressant, you can have suicidal threat. So now you need to be able to differentiate what is an antipsychotic for crazy people, people that are, local, versus somebody that is depressed. You can be depressed and can be depressed, And when you are depressed, you can have suicidal ideation. And when you're taking antidepressant because you are depressed is when you can have the suicidal risk. So you need to differentiate the quetiapine, risperidone, clozapine, haloperidol, aripiprazole, etc., that are antipsychotic medication from fluoxetine, sertraline, paroxetine, citalopram, that are the most common SSRIs, okay, used for depression that could have relation with suicidal threat. So now, in this way, you have a basic first aid orientation about pharmacology of mental health of the two more common problems, okay? The use of antipsychotic medication and the use of antidepressant medication, especially SSRIs. You need to know that, okay? The nurse expects to find the following signs and symptoms in a client with acute cholecystitis. Okay, you need to know what is cholecystitis. You have a gallbladder. The gallbladder is in the right upper quadrant. below the liver. And when you have gallstones, it can become inflamed acutely. And you have super infection. Oh, yes, it's a super infection, Beijing. Yes, it's a change of the flora. It's a displacement of the flora. It's a translocation of the flora, so it could be super infection. And you can have a infection of the bladder, or the gallbladder with bacteria. It's called acute cholecystitis. And you anticipate what the patient is going to have pain and have fever, and are going to have those symptoms. So abdominal cramps. We define abdominal cramps when it is originated, is a pain, intermittent, that is originated in the intestine. Okay, is originated in the intestine. The pain of the cholecystitis is continuous, it's not cramps. So when you see abdominal cramps, you think in colics in your intestine, that everybody knows what it is, because at least once in your life you had diarrhea and you know what is a colic in your intestine. It's not the usual. It's a sustained, continuous pain in the right upper quadrant. Hematemesis is not expected in cholecystitis, because you don't need why to bleed in the stomach, because you have the gallbladder inflamed. Fevers and chills, yes. Nausea and vomit, yes. Right lower quadrant tenderness, no. Right upper quadrant tenderness. And jaundice, yes, because it's a gallbladder. A nurse from the psychiatric unit is floating to the medical surgical floor. Which is the best client to be assigned to the floating nurse? So find the scenario. This is a nurse, a specialized nurse. It's a mental health nurse. It's a nurse that has not too much expertise in surgical and medical problems. But it's a nurse. Went to nursing school. And it's floating to the medical surgical floor. The two rules that you need to follow always to the assignating clients to a floating nurse are two. One, find an easy, stable client. And two, a client that has similarity, okay? Is similar to what the nurse is used to do. No, is used to do. Yeah. So now you have here a client with thrombocytosis, a client with leukocytosis, client to thrombocytopenia, and client with leukopenia. Of those clients, what is the most stable? And which one is here doesn't apply, is used what they do, because nothing of this apply what they do. But of these four clients, which one is the most stable? Which one you said? Don't be coward. Don't be cowards.
I mean, this is the most stable. I was thinking in the last one, because of the leukopenia. I was thinking in the.
I don't think the leukopenia is a patient stable.
No, I know. I think that I thinking in the leukopenia, because the side effect of the antipsychotic.
Yes, but it is.
But it's not the. Yeah. In this case, should be the first one. There is the thrombocytosis.
Yes, the first one is the one that has highest stability, because having a thrombocytosis, elevation of the platelet, is not an immediate threat to life. Of course, it's a risk. A risk for what? To forming in one moment in the future, forming a clot. And what medication you anticipate is usually ordered to clients that have high platelet?
Heparin.
No, heparin doesn't affect the platelet.
Should be anti-aggregate.
Clopidogrel.
Exactly.
Aspirin or Plavix.
Aspirin or clopidogrel, and aspirin and clopidogrel are tablets, So a patient that needs to be given, a patient that is stable, because high platelets doesn't present any symptoms, any problem, unless in the future, as a risk factor, develop a clot in any part of the body. Could be in the brain, in the heart, in the whatever. So what the doctor is going to order to a client that is having thrombocytosis, aspirin or clopidogrel, because are the medications that are antiplatelet aggregation. Do you agree with me? No, heparin has not influence in platelets. Okay, the only relation I can have heparin with platelets is that 1 in 10,000 clients, heparin can induce something called heparin-induced thrombocytopenia, which is very serious because it's an immunological reaction that can trigger a disseminating intravascular coagulation. But it is very rare. It is low platelets, but because an autoimmune reaction, not because the action of the heparin, but it is associated with, it's triggered by the heparin, but it's very rare. The heparin should not affect the platelet. Heparin affects the coagulation factors that are different from platelets. The medication that affect platelets or inhibit platelets aggregation are aspirin, clopidogrel, the antiplatelet medication. Okay, a patient with leukocytosis, you assume that is infected. A patient with thrombocytopenia is a risk for bleeding. Is a patient that is unstable. Is an immediate risk for bleeding. Patient with leukopenia is a risk for infection. Is a specialized patient. So the easiest patient there is the thrombocytosis. It doesn't disqualify my second option. That was what misguided you. Yes, it's true. But in reality, any hematologic alteration is the usual in psych. Okay, the presence of a patient taking clozapine with leukopenia immediately makes this patient to be transferred from mental health to be evaluated by the hematologist. No, okay. Okay, well, time flies when we're having fun, okay? Those are 2 questions that I wanted to practice with you, but I felt that you need also refreshment of important details of the content that I suspect that some of you are, weak. And I just wanted to go over this stuff, okay? So any question, any doubt respect of this? No questions? Are you okay?
No. Thank you,
Okay.
Professor.
Thank you for everything.
So please study hard and let's gather again, this Thursday. Okay? Bye-bye.
Thank you, Professor. Bye. Thank you.
Bye, profe.
Bye.
Bye, Professor.
Thank you, Professor.
You.